on behalf of ISMOPH, I welcome you all to the workshop Public Health Education Developing Need-Based Competencies. This workshop will be chaired by Professor Shomik Rajgupta, who is now Professor in the Department of Community Medicine, Bardhaman Medical College, Bardhaman, and co-chaired by Professor Budhairul Haq, who has come all the way from Bangladesh, but he has not yet arrived right now. I welcome Professor Rajgupta to come in the chair.
Thought it would be better to start in time for our co-chair joins. My task is to introduce the workshop and definitely the speakers. We have eminent speakers from different parts of the world. So first of all, on behalf of the organizing committee of the International Students Meet on Public Health, I welcome you all to this workshop on public health education developing need-based competencies. We are thankful to the organizers of the 14th World Congress on Public Health for facilitating these pre-conference workshops as a satellite event of the World Congress, and especially because identifying the topic of public health education as a priority area for discussion. 4 years back, when Hippocrates first shifted the onus of disease causation from supernatural to natural cause, we have progressed long way. We have the great landmark evolutionary things in our public health achievements, and journey started with landmarks. From Edward Jenner's experiment with cowpox vaccine to Johnson's investigation of prostate cholera epidemic, to Louis Pasteur's identification of bacillus anthracis, and the experimentation with rabies inoculation, James Lynch's unique solution for scurvy to solve cancer is polio vaccine. The list is really very long. These are the greatest triumphs of public health we have seen in 20th century. But having said this, we must admit that the achievements, though landmark achievements, made so far are mostly in the areas of communicable disease, and that too, the diseases which can be preventable by vaccines. I think most of us will agree that these are rather easier targets or softer targets when you consider disease control, eradication, or elimination. We have controlled the diseases which can be controlled by a sort of vaccine or some antibiotics. But what is left today are more complex health issues, where a shot of vaccine or doses of antimicrobials may not sufficient to control the problem. The public health problems which we are facing today are multidimensional. Lifestyles, behavioral factors, environmental issues, social and economic issues, all are playing a very complex role. And this needs an approach that is holistic and which integrates inputs not only from the field of medicine or public health science per se, but also from social and behavioral sciences, economics and medical sciences. The public health education system should take into consideration the present global socio-political scenario, the impact of globalization and economic liberalization in the health sectors, the impact of rapid scientific advancement, including science of medicine, and the reform process through which we are passing through. There is a need to relook into the public health education and training systems. This may include redefining the objectives, curriculum revision, newer training methodologies, monitoring and evaluation mechanisms, and sustained regulatory and quality control issues of the public health education system. Developing an effective public health system and ensuring universal access to healthcare immensely depend on the status of public health system and the nature of manpower it produces. The common criticism against the present system are that it fails to inculcate appropriate skills and competence among learners to serve the community effectively. Developing a societal need-based feasible public health education system is a challenging task. In this workshop, we have experts from various parts of the world who are playing a leadership role in designing and implementing public health education policies and systems. It is a great opportunity for public health professionals to mutually share their views and experiences, and thus it will be enriching for all of us. The presentation and discussion may contribute substantially to reforming public health education system in India and all other countries. Thank you. Now, I will request Kaushik to continue to start the first presentation, which will be by Professor Mujahid Rahman, who is head of the Department of Community Medicine, Anwar Khan Modern Medical College, Khanmundi, Dhaka, and Executive Member of Public Health Corporation of Bangladesh. And we just very briefly talking about the next presentation. Then we will have a health day, followed by, we have one session. Dr. Rahman will be talking on objective setting in public health education. Our next session after the health day will be by Dr. Sanjay Jodha, who is Director of Indian Institute of Public Health Delhi. His topic will be transforming public health education in India through reforms agenda, contextualizing global perspective. Then we will have a session by Professor Francisco de Campos, who is the Executive Secretary of National Open University for Unified Health System of Brazil. His topic will be public health education, alternate modalities using IT and distance learning. Then we will have a session by Professor Subhash Salunke, who is Senior Advisor, Public Health Foundation of India, New Delhi, who will be speaking on developing public health care in states of India. We will have a session by Professor E. Kadisharan, who is a faculty in the University of Leeds, UK, and Subdean for Postgraduate Examination, School of Medicine, UK. We will be talking on public health education, developing a comprehensive approach for India. Following lunch, we will have the last session by Professor Mujahid Rahman, who is also the co-chair of this session. He is the Senior Advisor, World Federation of Medical Education and Chairman, Public Health Corporation of Bangladesh. We will be speaking on accreditation of public health education, focused criteria. And lastly, I think with all the speakers and resource persons that are available, we may have some concluding session, opinions and reports. Thank you. Kaushik.
Our first speaker is Professor Mahfuza Rahman. Professor Rahman has graduated from Rajshah University, Bangladesh, and did his post-graduation in community medicine. He did specialization in medical education and obtained the degree of MHPD from the University of New South Wales, Australia. He has been actively involved in promoting quality assurance in undergraduate medical education and contributed in promoting the theme of social accountability in medical colleges as an executive member of Public Health Foundation of Bangladesh. Currently, he is closely associated with the activities of quality assurance in medical education, human resource development, students assessment and academic administration, and also in public health and educational research. He has many national and international publications in the field of medical education and public health, and also contributing in promoting the theme of social accountability of medical education institutions in Southeast Asia. I now welcome Professor Mahfuza Rahman to speak on objective setting in public health education. Dr. Rahman, please.
Good morning. Good morning, everybody. I'm Professor Mahfuza Rahman, as already said. First of all, I'd like to thank the chairman of the session. I'd like to thank you, everybody, the August gathering. My presentation is on objective setting in public health education. So, in the universe piece of the chairman of the session, he has pointed out many of the facts of public health challenges challenges. This is a sort of educational paradigm shift we need to address. So from that perspective, I'm just giving you some of the outline of my presentation and the way I will put it on. First of all, let us see what is public health and what are to determine it and how it differs from vision, what I mean, the clinical point of view and public health point of view. That is a big issue. Still, there is a big issue. And as the chairman already pointed out, that now focus is holistic. And focus is holistic, should be holistic. It is from the service point of view. But it should be from the educational point of view as well, because our educational settings must be in the way that we can provide service in the holistic. That's the point. That's why I'm saying this one. Challenges and obligation. We have many more challenges. We have environmental challenges in addition to microbes. We have challenges to zoonotic diseases. We have challenges to social factors, so on and so forth. We have challenges to natural calamities. So all these are challenges. And we have certain obligations as well. I'll come to that. And thirdly, skills and function. What I mean, that the modified skill, what I would like to say, that the Dr. Charles Bolen's 5-star doctor's point of view, that a doctor is not only a caregiver, but he has to play many roles. And that's why he needs a lot of skills to achieve all those and a lot of team and way forward to overcome. So considering all these facts and figures, as I have pointed out, so considering all this, I think our educational settings as well as our curriculum as well as our objectives of public education needs to be considered, needs to be redesigned accordingly. So that is the overview what I would like to say. So let us see what public health is. So there are many definitions. I am not going to all of this in detail because there is a definition from Charleston's law definition and other definition. But the main thing is that you have to see public health issues from population perspective, number one. And your knowledge that technologies should be directed towards this, using the optimum financial resources of that particular region or particular state or something like that. So that is the overall theme of this definition. And the Winston Charles Winston has already stated it earlier that it is the promotive, preventive, and curative, so on and so forth. So how it differs from medicine? As you all know, that public health is population. And the medicine is mostly individual. This is very clear. And then if we give a little bit in depth of this, that we want best outcome from the individual health perspective. But from population perspective, we want a healthy community, and which is the global theme of this century. So we need healthy community and we need a balance in allocation of resources as well. So that is lacking perhaps. And these sort of things we need to address in developing our new generation public health physician. And if you compare with the diagnostic tools in public health as well as in medicine, we see a lot of difference. You know that individually we need certain, I should say that like thermometer, stethoscope, and individual clinical history and so on and so forth. But when you deal with the population, the scenario is different. That we need to know the demographic that is population structure. What I mean, the population structure sometimes, because in most of the regional countries you see that our baseline population is mostly dependent population. But that sort of things to be balanced. That's why vital status is important as well as epidemiology is also important. Because in dealing with population, epidemiological, in community medicine we say that in community diagnosis, and community diagnosis, that's the community diagnosis. So, a public health specialist or a public health education epidemiologist should have a role to play in diagnosis community, particularly in each and every segment of population. And you see, if you look into the role of epidemiologist, what is his role? His role is nothing but he's an observer, and what I should say, that a detective observer. And he is to see the potential causes, where diagnosis, what sort of diagnosis? It is not individual diagnosis, but it is community diagnosis. And to design and implement a response. And on the basis of community diagnosis, he will design a response. I can give an example. For example, you see that most of the countries like India and Bangladesh,
Could you please be quiet?
you will see that accident is a problem, disaster is a big public health problem, with public health issue. So, the mitigated response should be starting from preparedness up to recovery as well. So, these sort of things, and epidemiologists can predict, epidemiologists can make himself prepared for that, so that the effect will be little within range. So this is one of the areas that public health tools might be engineering, enforcement, and education. That's why I'm telling you, and Chairman has rightly pointed out that it is not the responsibility of the physician alone; it is the responsibility of the other sector of the population. If you want to mean that you can handle the accident problem or prevalence of accident, but you cannot until and unless law enforcement authorities, the engineering people, the transport authorities, these people are not well conversant to deal with this issue. That's why the public health tools can be considered as engineering report and the enforcement, legal report, as well as the educational report of the person concerned. And now see the determinants. And you must have an understanding, and you have an understanding, I guess, that public health is a complex issue. And if you look if you examine the determinants, I'm not reading all those points, you see that disease is not the single event. A lot of factors are incorporating having a disease or having a public health problem. So you have to take care, or we will have to take care, and that's why our population, the future public health, healthcare providers need to have that much of perceptual obligations that is to take care not only the single determinant, but is to take care. And that is what honestly focus. So these are the health determinants we need to address. And same to the environment. We have a lot of environmental issues to deal with. And starting from vectors, starting from animals, as well as the climate change, megacities, population migration, so on. All these are the public health issues, and it does not involve only for the physicians or only for the doctors to cope up. It involves other sectoral population, expertise you need to involve. So these are the factors and inequalities, you all know that these are also the issues we need to address: economy, culture, environment, society, social norms, and lifestyle, individual lifestyle. Overall, these are the influencing factors for the population to become having a health problem. So knowing all these factors, determinants, you see that as I have already mentioned, that this is a complex in terms of management and monitoring. The doctor might have an understanding that I am only to take care of the sick, but not that. He has to take care of the sick as well as he has to take care of the healthy people in rendering promotive service, in rendering preventive service. And not only that, as the leader of the team, he has to manage the team properly. He is having a team, he is the leader of the health team. From that perspective, you need to manage, you need to monitor. And secondly, see that financing and service provision. What I mean, that financial involvement is everywhere. And if you have a very big program, but you have no resource, that will not work properly. Keeping resources in mind, you have to take strategy. That's why financial management is very important. Resource mobilization, according to, we should say that it should be equitably distributed, not equal. Meet legal challenges and meet ethical challenges. That is another aspect we must have to take care. And healthcare coalition, that means it is other sectors, allied health sectors. So that is why a public health professionals or public health managers or public health leaders should be in a way like this, and our educational system demands it right now to be, if you want to deal with the population at large. So our challenges and obligations, look, these are the challenges towards final goal, and this is the constitutional framework. First of all, we need some changes in public health sector, like for regulatory changes, and financing and pooling, as well as purchasing and delivery models. So these are the changes we need to adapt ourselves. We need to adapt in our educational settings as well. And then our intermediate goal, like equity and access, effectiveness and quality, financial sustainability, efficiency and productivity, and finally satisfaction. These all are the parameters as an intermediate goal. Otherwise, you cannot achieve the final goal, like health status, financial risk protection, as well as social responsiveness. So we want to achieve the final goal, but before that, we need to overcome changes, we need to overcome the intermediate goals, then we need to achieve the final goal. And that will give you a healthy population in a state or in a locality. We have other challenges, like as I have said, that we have some social challenges, we have some environmental challenges. You see that there are a lot of transmission from animal to humans, what we call zoonotic. New diseases are mostly coming as a zoonotic because the space is occupied by the humans. That's why there is no forest. Perhaps they are come to the human habitats and creating problems for us. The climate and environmental changes, as you are all aware with that, poverty and neglect. Still, we have some poverty in most of the regional countries. Weakening of health infrastructure, that is also a burden for us. Uncontrolled urbanization and population displacement. Most of the mega cities have this problem, and human behavior. Till then, we have many problems related with behavior, particularly social diseases, including the modern, I should say that drugs and other things might have related with behavior. So that's issues. Antimicrobial drug resistance is another issue, very important for re-emerging is a problem coming up. In addition to HIV, tuberculosis, malaria resistant tuberculosis, these are the public health problems as well as social problems. So we have certain obligations. See, as a physician, as a public health specialist, or as a healthcare provider, We have obligations of prevention of epidemics. We have obligation of spreading of diseases. This is our obligation, moral obligation, but it should not be like that. We have to protect environmental hazards, prevent injuries, and promotion of encouragement of healthy behaviors. And regarding the promotion of healthy behaviors, I would like to add that it needs to be incorporated to educational sector. I mean, from primary education to junior education. So healthy behaviors. I just say you one example that most of the now many of the educated people they have given up smoking, but now the teenager people in my country, I have seen that university going people, medical college and other things, this sort of teenage group or younger age group, they are still having that problem, smoking problem and drug problem of course. So in that case, you know, that you need to be encouraged healthy behaviors. Respond to disaster and assisting community in recovery. The community in recovery that is very important. In my setting, you see that people now know that they need certain precautionary measures after disaster. So they take it early. They take all these precautionary measures. So you can mitigate like that by involving education. Many of the problems we can mitigate by encouragement of healthy behaviors. Assuring quality and accessibility to health service. That is also important because still we have lack of access to health services in many parts of the country. Implementation of sustainable quality assurance and accreditation mechanism in public health education. That is the last part of the list. There are many more education. In my country now, 63 private medical colleges. I am working in a government medical college as a principal medical college. You have heard the name of Medical College, Bogura. In that place, I was the principal for 5 years. Then I came to the postgraduate institute, NIPSAM, National Institute of Social Medicine, and I retired on 2009. So, but problem what I am saying that mechanism of accreditation and quality assurance because everybody bothers about the quality of service, quality of care, so on and so forth, but nobody bothers about the quality of education. That is very big gaps and gaps because institution is opening, doctors are being produced, curriculum is there, but whether it covers the adequate quality, what should be the accessibility of the students in regards to provision of curriculum content, provision of teaching learning materials, or what the way they are being assessed, whether the assessment is should we say valid or not. That sort of things is not prevailing. But nowadays we are trying, some of the medical colleges having their schemes on quality assurance mechanism. In my medical college, I am one of the, quality assurance body, the phase, we have 3 phases, phase 1, 2 and 3, the para and clinical system, we have 3 phases. And I am one of the member of the quality assurance body, senior member of the quality assurance body. And I am performing this quality assurance scheme in my medical college. So, but in most of the private medical, as I am working in a private medical college because I have the previous experiences and that's why I am implementing. But there are many medical colleges. We have 63 medical colleges in the country now running and 25 plus government medical colleges, nearly 100. So this is a big educational program in the health sector is going on, but without maintaining such sort of qualification scheme in education as well as accreditation. We are lacking. Professor Madhav said details in the presentation, and the last presentation, say something about that. So these are our obligations, and we must take care of this issue. Otherwise, it is very difficult to say that we are providing or we are generating manpower in a way that people desire. In conclusion, I can say that public health practice should be based on scientifically sound strategy, improving the quality of life and reducing morbidity and teenage. That is our ultimate missions. Moreover, if we look into the scenario of the healthcare in the developing countries, we see strengthening of healthcare infrastructure and greater budget allocation. Prioritizing education, stakeholder education still is an alarming problem. Improve vaccination coverage, implement national health programs effectively, use scant resources judiciously. That is very important. In most of the wastage of resources is a very common factor. But scant resources, if you can use it properly, that is a good way of adjusting things. And lastly, include stakeholders in planning and policy. This is the area which is done, particularly in the remote areas. We need to involve people because people, those who need service, they need to be incorporated and they need to be, what I should say, participatory role. So now let us examine the skills and functions needed to consider of the setting of communication. First of all, skills. You see that these are some added skills in public sector and they have been identified. I have seen in many journals that monitor health, a public health specialist is skilled in monitoring health, diagnose and investigate, inform, educate and empower, mobilize community partnership, develop policies, enforce law, link, true and provide care, assure competent workforce, evaluate services. So these are all the essential skills as identified by many of us. So we must take care of these issues when setting public health educational objectives. So you see that the public health specialist must have infectious disease specialist, public health specialist, telecommunication, information specialist. Not specialist, I mean not like that, but it should be at least conversant with using these areas, information management, international field experience, and everything. So these are the added skills for public health specialists should have. So functionally you see that three functions differs from other domains. You see that you need to assurance, assure competent workforce, linked to the provide care, enforce law, as I said, and monitoring health, diagnose, evaluate, inform, mobilize community partnership, develop policy. So policy matter, assessment matter, and assuring matters. So these are the matters need to be dealt with by the public health physicians. So that needs to be as a function, he should take care of his functional responsibility. And we see that this function he cannot do alone, but he needs support from the region, support needs from the national, needs from the global. So that's also synergism needs to be developed. What we call the networking or linking. So way forward. The last part of my presentation is how we improve. So best public health practice is multifactorial, as our chairman already pointed out, and I am also telling in the same line that you need coordinated, well prepared and well equipped public health system. Partnership, clinician, laboratory personnel, public health agents, improve methods for detection of factors. There are many methods, but I must say that early detection, there are a lot of early detection methods, particularly I can give an example that cervical cancer, breast cancer, this can be early detected, but nobody bothers about that. They are not, comfortable to invest money on that. If you can detect early, and if you can detect late, this scenario will be different. A lot of resources mobilized if you detect it late. But the area where you can detect early and get benefit more, you can invest money that way. And lastly, quality public health education. That is our domain in today's presentation. So consideration for objective setting in public health education. Specifically, I would like to say that educational objective should be in the direction of local, regional and international perspective. Context is different in different regions, different countries. Therefore, the education setting should be accordingly. Focus in giving health of public health problems and hazards. We must focus accordingly. Addressing the public health problem of specialism is very important, particularly vulnerable, emphasizing preventive, promotive, and related education interventions. So our educational objectives, in setting educational objectives, we must be very concerned about all these issues. Being in relation to enforcement of laws and public health regulations towards development of leadership to manage coordinated healthcare. As I have already said, I will say, otherwise it is not possible. Be in the direction of capabilities to deal health problems in a holistic, through evidence-based research towards improved population-based health education practice. So that is perhaps the major challenges. I should say our educational system must be in that direction. Otherwise, I cannot cope up with the population. Finally, I would like to say thank you everybody for session sharing and to give the opportunity to say something in front of you. Thanks, Mr. Chairman. Thank you very much. Thank you.
Let us welcome Professor Madhumita Dobe, who is the Honorable Chairperson.
We have kept on communicating for government
Now the
action.
actual communication, two-way communication. Thank you very much.
Thank you, Professor Mahajir Rahman.
Professor Raman sir, just Dr. Dashmukh will hand over the certificate of appreciation.
We have heard a very precise overview of the task expected from a public health professional, societal needs, and how to identify the necessary skills. Now we will have a presentation on transforming public health education in India from the global perspective. I will request Professor Sanjay Jyoti, Director in India of Public Health, please come. And I will request
Professor Sanjay Jyoti is presently the Vice President North and Director Public Health Education, Public Health Foundation of India, that's ISMOPH, New Delhi, and also holds leadership position as Director at Indian Institute of Public Health, Delhi. Earlier, he worked as Professor at Department of Preventive and Social Medicine, faculty in Clinical Epidemiology Unit and Vice Dean at Government Medical College, Nagpur, India. He also holds joint appointment as adjunct faculty at Jian College of Public Health, Georgia, Southern University, Georgia, and adjunct professor in Public Health Leadership, Gillings School of Public Health and University of North Carolina at Chapel Hill, USA. Dr. Jyoti completed his medical MBBS, MD, and PhD from Government Medical College, Nagpur. He has also acquired postgraduate qualifications in sociology, public administration, and economics from Nagpur University. He has been involved in several major national and international research initiatives which have contributed significantly to the field of public health. He is the editor of Indian Journal of Public Health and associate editor of Frontiers in Public Health Education and Promotion. He is the member of Executive Committee and Vice Chair-elect of Global Evaluation and Monitoring Network for Health. He is also the member of IOM Global Forum on Innovation in Health Professional Education. His current professional interests include health systems research, health workforce development, education of health professionals, maternal and child health and vaccinations. Dr. Jodhpur will be speaking on transforming public health education in India through reforms agenda, conceptually global perspective. I invite Sir to take the stage.
Thank you so much. Thank you, Professor Samir Dasgupta. At the outset, let me thank you personally and Professor Madhumita Dode and the organizing committee for inviting me to share my thoughts in the context of how do we transform public health education in this country, and that too learning from what's happening globally, and how do we use and bring those learnings for bringing reforms in public health education in this country. That was the context actually. Ladies and gentlemen, delighted to have you today for this deliberations in the context of public health education globally, and I would mainly focus on contextualizing those to Indian scenario. What first I would do is that I would briefly speak to you on about what is the global perspective of public health education currently. And when you talk about the global perspective, that reminds us about the health professionals for the new century, that's a Lancet Commission, which was constituted recently, and 2010 they came out with their recommendations where they undertook the landscaping of the field in the context of identifying the gaps and opportunities, and they looked at three professions: medicine, nursing and public health. And public health remains the important and integral component of the Lancet Commission recommendations, where they used a multi-professional perspective in understanding and landscaping these fields. And they used systems approach, the context of the systems approach, and also looked at the linkages between the education and health systems in the larger context of these three professions. And what happens is that they takes us back a century at the beginning of the previous century, where these three reports that one can see here brought a lot of reforms and initiatives in the context of nursing education, medical education, public health education globally. You can see the Flexner report actually, which focused on transforming and revolution in the context of the medical profession. You have another reports where nursing report and the other report which focuses mainly on the public health reform that has happened at the beginning of the last century. And what happened is that these reports and several other reports basically has resulted into undertaking a lot of studies and research in the context of the field of education, which resulted in the ground-breaking reforms for the previous century. When we linked up science with the curriculum at the university, that was the focus of these reforms, where they linked up the science with the reforms in the context of the curriculum that had happened at the levels of the universities. And it was also attributed to doubling the lifespan of the human beings in the previous century has been identified as one of the important contributors actually, where the professionals were competently created who contributed in improving the health of the people, which contributed in improving the lifespan of the people. But at the beginning of the 21st century, where do we stand today? That had happened in the previous century. The education reforms at the beginning of the previous century has contributed significantly. But where do we stand today? That's the question that we need to answer basically. And if you look at the situation in the 21st century in the health context, and in the morning also, in the morning session, that we looked at some of the issues that the earlier speaker has raised in the context of the health systems and public health, but we would appreciate that there is a collective failure of sharing the dramatic health advances that have happened actually, which resulted into very glaring gaps and inequities and inequalities both within the countries and between the countries. That's what is the current situation is all about. And we are also actually confronted with the newer health challenges which centers over the health security. Newer infections are coming up. We have environmental and behavioral risk, rapid demographic and transitional epidemiological transitions happening, and that has contributed to increasing complexity, and the cost of health systems have risen like anything. So these are the challenges that we are currently confronted with in the 21st century. And it has been very comprehensively based on evidence that say that health education, health professional education has not kept pace with the 21st century challenges. If if we wanted to respond to the challenges of the 21st century, we need to see that how we revisit and reconfigure the health professional education globally to respond to these challenges. And what are those challenges? Why do we say that professional education has not kept pace with these challenges? Why is that so? If you look at globally, and that Lancet Commission has observed there is a fragmented, outdated and static curricula that most of the education institutions and universities globally, mismatch between the competencies to the patient and population needs, the competencies that our graduates we want them to perform at the end of the program, the competencies they bring out of the program, there's tremendous mismatches there. Poor teamwork, the focus is not on the teamwork. Narrow technical focus without broader understanding, contextual understanding of the situations. Episodic counters rather than the continuum of the care that is being clearly reflected as part of the failure of the professional education. Predominant hospital orientation at the expense of the primary care. And that risks therefore the PTQ graduates. And quantitative and qualitative imbalances between the professional labor market that see that the need and demand paradoxes prevailing, all in terms of doctors and nurses and public and professionals that are being produced, and weak leadership to the health system's performance. So these remains basically the challenges in the context of saying that our professional education has failed to respond to these challenges. And that has required actually a thorough and authoritative re-examination of the current professional education, which also includes public health education. And therefore, what has been recommended by the Lancet Commission is 3 generations of educational reforms. They said that if you see that at the beginning of the previous century, the focus was on the reforms related to the science-driven. Those reforms were science-based reforms. If you see the previous century around in 1960s, that time the focus shifted from science-based reforms to problem-based learning. If you see that 60s to 80s, a lot of focus was on problem-based learning. At the beginning of this century, what we need is focus on systems-driven, health systems-based thinking basically, health systems-based education. That's what is required. And therefore, we need to move from like when the science-based reforms were talked about, the focus was on having the scientific curriculum. Even at the beginning of the century, that was required that we need to have the scientific curriculum where the university plays. We moved on problem-based learning where we thought of an academic centers. What we need currently approach is a health systems driven, but we need a competency driven education with focus on local and global issues obviously, and health systems connectivity needs to be reflected as part of our educational programs so that we create the graduates which are more suitable, competent and motivated to work in health systems, particularly in the context of the developing countries. And why we say that? Because this interface of education system and health system is extremely critical and important. And unfortunately, even in India also, and several of us would agree to this, that there is hardly any dialogue between the education system and the health systems. Unfortunately, that's the story globally also. We create graduates whom we expect them to work in the health systems, but unfortunately, there is very limited interface and limited dialogue between these two systems to exist. Because we need to understand that there is a population, and we need to respond to the challenges, public challenges in the context of the population. If we take an example of the health systems, because the needs for the health systems, that the health needs, they would emerge from the population. And once we feel that these are the felt needs of the population, health needs of the population, these needs get transformed into demand. Because we as a population, as a society, then we demand healthcare basically. And healthcare is being provided, and for providing that healthcare, what we need is the competent and motivated health workforce. And if you look at the other side of the story, that's an educational system, from the population only, there will be a need of actually having people trained in public health or medicine or nursing professionals. That gets translated into demand because we need people actually who would provide the healthcare, and therefore we need to provide, and that becomes the supply of the health workforce. The supply of the health workforce, which also includes public health professionals, and demand of the health workforce, they create the labor market, which actually needs to be responded in saying that this interface of the health and education system is to be sorted out, where we have right workers engaged with the right problems at right places and solving the healthcare provisions. That's the context that was thought about, and therefore, what we need when we say all this is that we need new instructional and institutional strategies to to actually respond to the challenges which are surrounding the current health professional education, which also includes the public health education. And therefore, this framework of the institutional and instructional strategies has been recommended by the Lancet Commission, where they say that we need reforms at two ends, basically, at institutional level and at instructional level. And one can think about, like, for the instructional level and design, where the processes, the criteria of the students being admitted, actually the competencies, the challenges that the way we teach them, the career pathways that we talk about, and at systematic level, we talk about the stewardship and governance. We talk about the resource generation and the service provision. At organizational level, we talk about the ownership, affiliation, internal structure, and global level, the networking and partnerships and stewardship. That means the proposed outcomes basically would be interdependence in education and leading into a transformative learning. And when we talk about this transformative learning, then we talk about as part of the reforms and the instructional reforms, we talk about we need competency-driven approaches to the education that we offer. What we need is inter and trans-professional education. What we need is IT-empowered education. What we need is educational resources, new professionalism. When we talk about institutional, we need more planning focus actually with the joint planning, academic systems and global network. And enabling actions in that context would be that therefore we need to mobilize leadership. We need to enhance investment also. If you look at the investments in health professional education globally, it's just 2% of the total amount that we spend on healthcare globally. So it's so bigger investment actually in the larger context of the health professional education is also a matter of concern. We need to align accreditation. And we have sessions today. We have a session on accreditation, we have a session on competency, we have a session on career opportunities in the context of the public health gather. We need to strengthen that and then to see, because finally the goal would be we need to have the transformative and interdependent professional education for equity in healthcare. Wanted to advance the agenda of universal health coverage, particularly in developing countries, including India. We need to focus on transformative education. That's what the focus is all about. Because we know that in the context that why we are emphasizing on transformative learning, because this has been considered as one of the most important drivers for the health professional education reforms for 21st century. But then what transformative learning is all about? Because we are saying that transformative learning. If you look at the levels of the learning, one can think of three levels of the learning. The first one is the basic one, that is informative learning. It's about acquiring knowledge and skills. And therefore, the informative learning would create experts. It talks about the knowledge and skills learning. But when we move a step further, basically, then we talk about a formative learning. A formative learning is just one step further than the informative learning, where we talk about even socializing students and around the values actually. The values and ethics, that those comes into a picture when you talk about formative learning, where then we would create professionals. Because from experts to professionals, because that's socialization of values is critical. But even a step further actually is required, and that is what is the transformative learning is all about, where we talk about developing those leadership attributes, creating change agents. Our graduates should not only be bombarded with the knowledge and skills and values, but it's so important to see that when they come out of the institutions, they are the change agents for the society. They want something to do in the society, and they have those leadership skills and competencies to function and work in the context of their systems, where they are not only the experts and professionals, but they are actually the change agents who want to bring that vibrant all architecture as part of the health systems are concerned. So that's the transformative learning is all about, which incorporates informative learning. It's not that without knowledge and skills that you can have those leadership competencies, but that's all about the transformative learning that we wanted today. It's not that very passive graduates, but we want more active, vibrant, strong graduates to come and contribute to the systems in this country. It's not only the Lancet Commission recommendations. If you look at several reports that recently have been created, some of them are presented here. Even the recipe declaration in Brazil that we have done for Brazil today, the conference that we had previous year actually, which focused on the health workforce development, also emphasizes the need of transformative learning. Even the future of nursing report produced by Institute of Medicine, and there are other reports basically which all focus in you would see last 5 years, there's a lot of emphasis on reforms in health professional education, and transformative learning is being observed and seen as a tool and instrument for the reforms for the health professional education. education, which emphasizes the need for revisiting the whole architecture of the health professional education, including public health education. That's the context that we want to see. But what's happening in this region? Now, moving on, this is what is happening globally that we currently talked about, and we also wanted to see that how do we use those global learnings for the regional context. In this region, actually, in Southeast Asia region, there are several initiatives being taken in last few years to advance the agenda of reforms in public health education and health professional education. I would tell some of them. We established this Asia Pacific Network on Health Professional Education reforms. This was created in 2011 post Lancet Commission recommendations, where the 5 countries of this region, Bangladesh, China, India, Thailand and Vietnam, we joined hands together to advance the agenda of reforms in this part of the globe, and sharing experiences and bringing innovations in health professional education. And as part of that, we undertook the situation analysis of the health professional education, which also includes public health in these 5 countries recently, and governments being at the center and front stage, that they are engaged with the governments, because we all know that you can't advance the agenda of reforms in education in isolation, and therefore it's important to be engaged with the government. So governments are actually engaged in the whole process of advancing agenda through this Asia Pacific network. That's an annual network that we have. We have Southeast Asian Public Health Education Institutions Network. Then we also in India have India Public Health Education Institutions Network, and both these networks provide the platform for discuss and advance the reforms. And both the country office here in India and even the CRO office, that is Southeast Asia Regional Office of WHO, has been extensively supporting the agenda of reforms, and I'm happy to note actually in promoting the networking partnerships between the health professional education institutions. They are all public health education institutions, most of them offering MPH programs, and even the sharing resources. I would also like to mention that even the last one only actually, we had a meeting in Bhutan which was coordinated by the WHO CRO, where the national governments, 11 countries of the CRO region participated, and the whole focus was actually how do we bring transformative learning as a tool and reform, as an instrument for the reforms in the health professional education in the CRO region, which was supported by WHO CRO. So these are some initiatives which are happening actually. This is something which was supported by the China Medical Board a couple of years back, 3 years, 4 years back actually. We looked at the competencies frameworks where we had participation from 4 countries actually. We had participation from United States of America, Association of Schools of Public Health and Harvard School of Public Health, and then we have a BRAC from Dhaka, and the Hanoi School of Public Health from Vietnam, and then from India, PHFI, where we looked at and compared the cross-country comparison of masters and doctoral level programs with focus on competency-driven curriculum. So to advance again the agenda of reforms, mostly focusing on competency-driven focus. The Institute of Medicine based in Washington DC has established 4 centers globally, supported actually establishment of the 4 centers globally, where they say that they are these centers, they are called as the innovation collaboratives, and the whole focus is to identify the innovations in health professional education with focus on public health education. And we have established Center in Public Health Foundation of India, through which we are engaged in again in advancing the agenda, mostly on 4 areas, actually multidisciplinarity to the public health, secondly the competency-driven education, then career opportunities and accreditation for the public health programs and institutions in this region. So that's what is happening. The 2 more efforts I would like to mention is that through the public sector linkages program, which is the office work together basically for develop the competency frameworks for public health professionals in this country. So through the organization, through the association basically, we're trying to see that how do we advance the agenda for the competency-driven education. So these are 2 efforts that I wanted to mention. More efforts basically. One is about the major evaluation supported some initiatives where we formed a network of institutions offering MPH programs in this region and in South Asian region, and we developed the competencies for MPH programs for the South Asia, where all the neighboring countries, Nepal, Sri Lanka, Bangladesh, they participated into all this particular initiative. The one more initiative that we are engaged is about, which is supported through the Welcome Trust capacity building grant at BHFI and 14 UK institutions that we have at grant. And Dr. D.K. Kanchan is today with us. Basically, he is one of the person who is involved in this initiative, and he represents that consortium also. Actually helped us to engage in designing and developing the competency frameworks of public health professionals. That work is currently going on, and we are presenting that as part of this initiative also. So these initiatives are trying to advance the agenda of reforms. I wanted to mention at regional level, there is a lot of commitment and engagement by several forums and associations and institutions and groups to see that how do we advance the agenda. But let's look at what's happening in India, particularly in India, understanding the landscape of public health education. Look at what are the public health education initiatives in India. And the third report is the 5 situational analysis of the health professional education. And summary of these 3 reports I will present in the next few minutes is that traditionally public health education in this country is offered through medical schools. That I am the product and several of the product of medical schools in India, where we used to have the community and social medicine. Now several institutions and universities call it community medicine as part of teaching undergraduate level in MBBS program. Then at the internship, actually is a 1-year internship program for medical graduates. Then there is considerable exposure and experience in the context of the community medicine. And subsequently, then we used to have, or we have rather, postgraduate level programs. We have MD in community medicine. Some institutions still call it MD in preventive and social medicine. And we also have diploma in public health and some other programs also. But traditionally, it has been offered through medical schools. But one of the major limitations was that the programs were only available for medical graduates, being taught by the medical doctors, because the professors in medical schools mostly are medical faculty, and are predominated by the physician-oriented, medical-oriented programs basically. There was hardly a scope of multidisciplinarity in the larger context. But what happened is that in recent last, I would say in 20 years, the first program that was the first MPH program that was launched in India was in 1995. So in the last 20 years, we had seen several education institutions and universities offering programs for having multidisciplinary background in the MPH program open for both physician and non-physician background, and there are institutions offering health management and epidemiology and several other programs actually. So there is a conscious shift of medical education from the corridors of medical schools to the schools of public health, which are much more multidisciplinary in that context, and health and hospital management institutions and other institutions offering programs in various domains of public health. That's what is happening. And these are the numbers. If you look at, forget about MBBS, because MBBS is not, we don't call them as typically people who are trained in public health, but because they have a community medicine education, we included them. But MD programs, and you can see the number of institutions and the annual intake capacity in this country. And the MD, then diploma in public health and diploma in community medicine, then MD in tropical medicine, health administration, community health administration, then MH program for, so all these programs up to even these diploma programs in the health education and industrial health and tropical and medicinal health, these are only available for medical graduates. But once you can look at below the MPH program, then in the MPH there are 35 institutions in India currently offering MPH programs and producing graduates. More than 900 intake capacity is currently there. There are programs in epidemiology, health management and hospital administration. There are more than 50 institutions in India which offer programs in health management and administration. So public health management is a program which is developed on the request of the Government of India, is completely contextualized to initially National Rural Health Mission and now the National Health Mission. And we have programs in occupational health and public health nutrition. So in different domains of public health, so these are the current status of the program. But what are the challenges that we are confronting currently? At the governance level, the issue of regulation, because the MPH programs are offered to institutions which are affiliated to the university. So under the domain of the University Grants Commission. And currently, we don't have any quality assurance and accreditation program or a benchmarking system, because like for medical schools, we have Medical Council of India, then we have the Nursing Council also. But for public health education, currently there is no accreditation existing in this country, and we are trying for that and we are pushing for that. There is need, demand and supply paradox also. On one hand, we say that we need people trained in public health. But we also struggle on the other hand, where do we place them in public health? If you look at the positions which are available in the health system, my colleague Dr. Subhash Saunke will speak in more detail actually, but we have challenges, we don't have positions basically. And in that context, we are trying to push the agenda of creating public health cadre, where earmarked positions of public health professionals would be available. Infrastructure issues of the institutions, partnerships and collaborations. Although these platforms are available in last 5 years, we would say that we have been successful in that, but still there is a most tremendous scope of partnerships and collaboration between the institutions, within the institutions, with the councils and the government. And career pathways in public health is also one of the governance issues that we are currently struggling. And therefore that results into a program and quality. If you look at the courses and programs also, it's not that on one hand I would say that there are 35 institutions offering MPH programs in India, but how is the quality of all these programs? I can't tell that all the institutions, there are very good institutions, but there are not so good institutions also. So we need to see how do we improve on the quality of the programs. These many institutions offer programs, but India has hardly any PhD programs to create the faculty. So from where the faculty would come actually, we need PhDs to, or even MD programs also, because those faculty, where the faculty, both in terms of the quantity and quality, remains one of the important challenge for that. Untapped potential of distance education in this country. Because we also know that a lot of people work as part of the health system and they cannot join for regular programs for 2 years or 1 year. And we need to see that we create a very strong portfolio of e-learning in public health. There are some initiatives recently, but that potential still remains untapped. Curriculum and competencies, Riki would definitely speak about it, but engaging stakeholders in the whole process of actually reconfiguring the curriculum of public health education programs and creating competencies. And it's very well said in Alice in Wonderland actually, if you don't know where you are going, any road will get you there actually in the context of competency. We need to have front and center what are the competencies that we expect, not at the end of the program, but even at the end of each module actually clearly spelled it out. And therefore we can then able to say that this MPH graduate or diploma in public health or the MD graduate, that he has these competencies. Our graduate must have those hip pocket competencies. It's not that the degrees would matter. I'm a PhD in health economics and I wanted to hire a PhD in health economics, and you check with them, are you independently able to do economic evaluation of the clinical trials, and then the person tells that he may not be economically independently able to do that. Then what is the use of that knowledge actually? We need to see graduates with those hip pocket competencies that they are able to function and perform the tasks and activities that we expect them to do actually. So that's the context of community-based education, health systems connectivity, all these issues surrounding our curriculum and competencies. And it would not be, unwise to say at this point in time, in Bhutan meeting actually, we had a group work and I was moderating that group work, and we came to, that would come in the WHO document also recently actually, we came out with a thought actually around the redundancy in public health education. And what we concluded as a group work is that 30% of what we teach is redundant, but the 70% the way we teach is redundant. So it's not that what we teach, it's not only the content and curriculum that is redundant, 30%, but the way we teach, the way the pedagogy actually, the way we teach basically is 70% redundant. So that's what is the challenge that we need to look at. Public health education that is irrelevant to the national priorities and diverse from public health practice is useless and constitutes a lost opportunity. I think that would be an apt to say at this point in time. We also need to focus on educational resources, needs incorporation of multidisciplinary thinking in the public health actually. We need learning teaching resources like case studies and innovation studies. We see on one hand that we need to use case studies for teaching in public. But unfortunately, how much is the engagement actually? How many schools and how many departments actually have designed and developed those case studies, used those case studies, evaluated those case studies? So the whole approach that we wanted to say that we wanted to shift, and not only the case study, I would say that there are several ways that pedagogy actually has advanced like anything. E-learning and innovations in pedagogy is very much possible actually. We need to see that both is the student-centric, competency-driven, and for that we need pedagogy is one of the challenges in that context. And not only that, possessiveness of those academic material. The time has come basically of sharing resources. It's not that this is something developed by me and I would use, actually why it is not being public domain and used by any other schools actually. Because finally what matters is that what benefits to the society. In that larger context of making these resources available to the open access, availability of these resources is critical. Faculty we talked about, but faculty recruitment challenges remains in this country, both in terms of quantity and quality. We need people actually trained faculty members, we need faculty development programs, systematic engagement into that, role models, we need multidisciplinary faculty actually in schools of public health. So all those issues extremely critical and important, and not saying that we need pedagogy skills, but we need to have a systematic and strategic efforts to organize these programs so that we build the skills and competencies of our colleagues who teach in public education institutions in advancing or enhancing their pedagogic skills. And therefore this is what actually I just mentioned to you, that 30-70 paradox. What we teach and where we teach. 30% of what we teach is redundant and 70% of the way we teach is redundant. That needs to be addressed, and that calls for actually the enhancement of those skills also. Finally, talking about even assessment also. As we say that we need a multidisciplinary curriculum and multidisciplinary faculty, because public health is not actually, it's not only the disease driven. Public health is such a wider scope, and in that we need multidisciplinarity element to be incorporated completely and exhaustively. In that context, methods of assessment, competency driven, because not to have the competency driven curriculum, but the assessment also should be done competency driven, so that, and then therefore the variable quality of graduates remains an issue. And therefore there is evidence for action also actually, because there is very limited research in public health education. We looked at it with the actually one of the ministry meeting, the Government of India Health Secretary asked us that how many institutions in India offer MPH programs 4 years back. They asked us, and we did not answer actually. Because there is no single registry where everything is registered. So there is a lot of scope for research in public health education. We need to actually, if we wanted to advance the agenda of, like for example, public health cadre. Now when Dr. Sarangi goes to the several states and he promotes the public health cadre, the question that is commonly used is that there is the evidence that this will make a difference basically. You know, even we have in some states like in Tamil Nadu and some other states that we present a model. So these questions will be, unless they are researched very thorough and we are able to convince the bureaucrats to say that yes, this will make a difference, then they would look at it, you know, with open eyes. Otherwise, that's a challenge. That requires a lot of research engagement in terms of actually this is better than this. Why suppose the wiki tells us that, you know, the case-based teaching actually, will that actually make education more fruitful and productive for the graduates? If we use that, we need research evidence, we need feedback from the students. So there are a lot of initiatives in the context of research in education that are important and critical. Even the 12th five-year plan which was articulated recently, now there is a transition in India as long as the planning commission is concerned, but this is important to mention. It talks about the commitment of the government of India, because this directly comes from the planning commission, which talks about public health education must be developed as a multidisciplinary, health systems connected, problem-solving professional course, and be open to both physicians and non-physicians. Expanding the capacity of examination, certification, accreditation bodies is imperative, because this is picked up from the planning commission, which highlights and which endorses the commitment of the government of India in the context of advancing the public health education reforms in this country, which are very much reflected here. So finally, if we wanted to advance the agenda of reforms in public health education in this country, we need to see that how to showcase public health as a field actually. Because you walk on the street and you ask, young people actually who are graduating from the school, and you ask them, they would say that they wanted to become a lawyer or a doctor or an engineer or a manager. But nobody would say that. They would say, I wanted to become a public health professional. Because people don't understand showcasing the field of public health. What is public health is also not understood very properly actually. Therefore, getting public health recognized as a profession and value creation is important if we really wanted to advance the agenda of public health. Enhancing the quality and relevance of public health education is critical through maybe accreditation of the programs and institutions. Systematic efforts towards creating job market and then public health categories is important. Organize resources and facilitate reforms. Time has come to change actually and innovate in a larger context. And therefore, what we also need is that we need to strengthen the public health leadership for that, and we need champions. We need champions, and because see, you have to pick up one agenda and you have to just be after that. You pick up public health cadre creation and then you have to be after that. Because getting something into the policy domain and policy arena is very challenging actually. So all these issues of accreditation and competencies, that we need champions in institutions, we need champions in governments, we need champions in associations and organizations to take that forward actually. That's what is the whole philosophy. Public health education in India is at crossroads, and we need to find solutions to our problems through the reforms. That's what actually I wanted to say, and therefore the transforming public health education is extremely important and critical. And there are several initiatives globally which are happening, so it's important that we learn from these initiatives. It's not that we copy paste them here. It's more important is that whatever is the best and can be contextualized to our scenario in developing countries in this particular region, we need to see that and figure it out. Thank you so much for this.
We have heard from King started from the historical perspective of the public health education system, the recommendation, the reform process, and the Lancet Committee recommendations, and today's challenges like the static curriculum, lack of competencies, lack of leadership, and the need for changing the whole process of public health education to ensure produce a manpower with adequate and appropriate competence to meet the societal needs. I will especially thank Professor Jyotpe because he has helped me a lot in organizing this particular day-long session on public health education need-based competencies. Because I personally had no knowledge about horticulture or Professor Salunke, their field of expertise. So Professor Jyotpe helped me to networking with them. And finally, we got them as speakers because this is one area where they have a lot of expertise. We'll hear from them in later sessions. So again, I thank Professor Jyotpe for his deliberation and Kaushik.
Professor Lakshmi sir, please hand over the certificate of appreciation to Professor Jyotpe.
Professor Mujahidul Haq, who is Senior Advisor, World Federation for Medical Education and Chairman of the Public Health Foundation of Bangladesh. He is a co-chair of this particular session on public health education. We welcome you, sir. We welcome you. We have started at 9:45, but I will invite you to that, please. Next speaker will be Professor Francisco de Campos, who is Executive Secretary of the National Open University for the Unified Health System in Brazil. We will be talking on transforming public health education, alternate modalities using IT and distance learning. I will request Kaushik to give a brief description about Professor Campos.
Professor Francisco Eduardo. He is a retired full professor from the Federal University of Minas Gerais in Brazil. Used to be a Vice Minister for Human Resources in Brazil and has a long-standing cooperation with WHO and Global Health Workforce Alliance. Professor Campos is the Executive Secretary of the National Open University for the Unified System in Brazil. Brazil has a solid formal system in which dozens of universities and public health schools offer face-to-face education ranging from specialization up to master's degree and to doctorate studies as well. The perspective of the Open University is to build something beyond and besides the formal education system for public health in order to address the public health and other professionals working for the national health system in Brazil. Through a consortium of 30 public universities, they are promoting IT-based massive open and online courses in a wide range of themes and formats, from specializations in PhD to epidemiological challenges to liquidity policies and so on, having hundreds of thousands of enrollments. So, Professor Campos will talk about the public offer of education through IT and distance education. It targets professionals working in remote areas, which comes from along with the e-health assistance. It encompasses public health themes and self-learning courses in topics such as dengue, leprosy, tuberculosis, and so on. So I invite Professor Francisco Eduardo de Campos to speak on public health education, alternate modalities using IT and distance learning. Okay.
Thank you very much to the organizers, and thank you for the outstanding conferences that we have heard before. My name is Francisco Campos. I'm, as I was presented, I've been 40 years in my medical school, the biggest one in Brazil, in public sector. But right now I'm in charge of open education for the professionals in the health system in Brazil. My first set of slides will be to contextualize you about Brazil, and after this, the second set, I will go to the theme of the presentation. As you know, this is Brazil. We are somehow similar to India because when the Portuguese came to Brazil in the 1500s, they thought mistakenly that they were in India because they were trying to circumnavigate the world in the other direction. So, because of this, for instance, the native population of Brazil is called Indians, Índios in Portuguese, because the Portuguese thought that they were here. So, we have a lot of things in common, including the participation in the BRICS. And Brazil is, the government of Brazil is one of the sponsors of this meeting. A little bit about Brazil. We have a population of 200,000 inhabitants, 4,000 health professionals. The life expectancy right now is 75 years. Infant mortality dropped a lot, but we are still ashamed of it because it should be much better than it is. We have 3 million health professionals in our country. We are the second country in the world in number of medical schools. The figures that we presented right now, I think India has 300. We are the second one in the number of medical schools, and we have 400,000 physicians at this moment in Brazil. Brazil is ashamed of its past of inequality. So this is a figure that tells more than 1,000 words. Neighborhood where people had swimming pools and golf courses, the side of the slums and the poverty. So for many years now we've been trying to fix this problem, to promote inclusion of the society. About 30 million people were taken from this extreme poverty in Brazil, but we are still in a problem, and I don't know how to speak about this in India, but we are still ashamed of our past. In Brazil, in our constitution, after the dictatorship in Brazil, in the constitution it states that the access to the Brazilian national health system is a right guaranteed by the national constitution from the primary to the quaternary level. So primary, secondary, tertiary, quaternary are guaranteed by the constitution. It's a quite decentralized system, so public health is an issue for us because all the system in general is managed by the municipalities. So there is about 100,000 managers in the system because they belong in general to the municipalities. If you think that Brazil has 6,000 municipalities, each municipality has 3, 4, 5 managers. The figures are quite clear. But the main organizer of the system right now is the national family health teams in Brazil, having 47,000 teams right now that organizes the attention, the public health and the medicine in the country. This shows you the political willingness to proceed with the primary health care in Brazil. If the dark blue points, this is up to 2010. The dark blue points mean municipalities in Brazil where more than 70% of the population was covered by the family health teams. So it demonstrates, right now there is 47. those figures go up to 31. So much more than this. Practically, we can tell you that there is no shortage of health professionals in Brazil anymore, because a quite controversial program that was to allow foreigners to practice medicine in Brazil. It's quite controversial in Brazil. A lot of discussion about this every day in all newspapers in Brazil. I can tell you that the family health teams, the 47, are composed by one physician, one nurse, one or two auxiliary nurses, one dentist in general, half of them, 6 community health workers. The community health workers are recruited in the locality, in the municipalities, and trained for those functions. But I can tell you that 70% of the Brazilian population rely exclusively on our SUS for us, the national health system in Brazil, and about 30% high private plans to their assistance. The same thing that 100% of the independently of this, 70% have the private plans, but all of them needs vaccines. And when you come, for instance, to complex medicine, for instance, transplants, in general they go to the public sector. So the public sector in Brazil supports all the primary, all the quaternary is like a cent block. It's not easy to explain this, but we can tell that in health promotion, in vaccines, 100% of the Brazilian population is covered by the national health system. We are the first country in the world in organ transplantations publicly funded. The vaccines, we have good records, and for instance, antiretroviral treatments, we are one of the countries that started this idea of making it universal. It's quite clear for us in Brazil that the problem of the health workers is the problem of that can organize or not the health system. We have many challenges. In the educational area, we have 35 technical schools that train more than 1 million health workers. And one thing that was important mentioned here, despite the fact that in the Brazilian Constitution, Ministry of Education controls the educational system and Ministry of Health controls the health service delivery, we are trying to bridge them. For instance, when I used to be vice minister there, we are granting more than 400 schools to ask them. You mentioned the report of the Lancet. I was in the work at Health Workforce Alliance at the site. So we are trying to, it's better to make a medical school, for instance, to use the primary healthcare facilities instead of using just hospitals, because in the future, there will be better professionals to assist the population if they know and they belong to a system where primary health care is the most important component of the system. In the education area, we have the residencies are driven a lot by the private and the medical association interests, and we are trying to turn this in order to have the public interest prevailing over the private interests. Right now, my institution, the Open University, at this time have 140,000 enrollees, 220,000 just for specialization in primary health care. And e-health right now in Brazil is available for almost all the public centers in Brazil. Probably we have the public funded the biggest e-health program. So any health unit in Brazil can reach next facility to know about the second opinion and to Brazil it's hard. I don't know the situation of India, but sometimes in the Amazon region, for instance, it takes 7 hours in a boat to go to the next facility. So if you have, we have the figures. E-health costs less than 10% of what should be the displacing the patient to the next level. And this is public responsibility in Brazil. So if the patient needs to go to the next center, public system has to pay for it. So if I have internet broadband connection in all the cities, I can easily to make the knowledge of the access to the next facilities to get there. In management distribution area, we have the same problems, incentivizing salaries. I not go through this. The 15, especially Cubans, right now are practicing in Brazil, reforming the health facilities. And finally, I go to what I was supposed to tell to you. A presidential decree establishes the open university that we call UNASUS, Universidade Aberta do SUS, Open University of the National Health System, that is a collaborative network of the universities. We did not have our own university. We think that if the public funds are responsible for having universities in the educational system, we have to work with them. We are not making a university of our own as Minister of Health, but using the universities that are already in place to do the education of health professionals. Those universities establish resources, a repository of open educational resources for health, and lastly we have the information, updated information about all the health workers in Brazil. If you need, I can go to have access to internet where are the neurologists in Brazil and how we need to train them in order to. This is a big effort that we saw. Three components. The network of universities itself, they adhere voluntarily to the initiative, so there is many hundreds of universities in Brazil. The ones that want, and the ones that are allowed by the Minister of Education to offer continuous and distance education can be part of the system. They contribute to the repository, and we have access to all the database of the health workers in Brazil. We have built so far a strong national network in health education. We have the largest educational resources repository in Latin America, and about 2.2 million health workers are registered, and we have the educational progresses in order to make the managers know what to offer, what are they doing, what are the capacities to do so. The principles are that the open access to health is must be quality for everyone. Learning is a lifelong process aimed at problem solving. So I agree with the presentation. I think it was good. And is focused in the student. The needs, the rhythm, and the learning style are set by the students. Today, most of our courses are based on Windows, are based on Android, and are based on iOS. So, for instance, I have a course about dengue. Dengue fever is an important thing in Brazil. The health worker can take a course of 16 hours in the tablet or in the cell phone, and to have, at the end, it completes the course, have a certificate issued, and I signed the certificate. So there's a lot of responsibility to do this, together with the authorities of the Ministry of Health. I mentioned the repository of educational resources. So far, we have about almost 2,000. This is not updated, but and what's important that right now it was basically in the past it was text material. Right now most of them are migrating to the multimedia, text, videos, interactive material, games. We are working a lot in this kind of using games for training health workers, for instance, in dengue fever to avoid dehydration. So it's important to create a technological platform that allows us to do this kind of thing. All the educational resources are uploaded in the platform. The university, when signs the contract to be part of the UNASUS, makes a commitment to upload all the educational material, and because it's paid by public resources, there is no individual copyright. This is probably the main problem that we have had so far, because all the authors want to have their copyrights guaranteed because they produce the material. But if they produce it, if it was already paid by public resources, there is no copyright for them. So it's public use. They give the rights of the publication to the Ministry of Health. Just to give to you, I'm not going to mention all of them, as what are the themes that there are materials produced so far. Women's health, children's, let's say. The ones that go after more than 50 are infectious diseases, health of elderly or older adults, children's health, women's health, and so forth. So the most common themes that come to the attention of the professionals of the primary health care. The collection has this as well. There's public health surveillance. So public health is a quite important thing because, as I told you, 100,000 managers in the national health system need information about public health practices. Just to put by the kind of material, primary health care, multimedia, text, video, interactive material, presentations, images, audios. Because what we do is that the material is uploaded there. So if other university wants to start a course, it doesn't have to start from the scratch in order to develop it. It can use and code what is the production. So there is a lot of discussions about copyrights on this kind of material. Right now we have 140,000 people enrolled in our. It's important to. There's some places in Brazil where never, if we used to make just face-to-face education, of course, then how we will those things. So the fact that we have many places, the capillarity of the system, allowing people going in the Amazon region, for instance, to be enrolled and to be in the courses and to present their very good thing. Because otherwise, to displace one person from here to here, to São Paulo, to Rio, it's 4 hours flying. So there is no sense, the cost should be absolutely prohibited in terms of the cost that Brazil has 27 states. All of them are enrolled in activities in our open university. We have 5.5 municipalities. 90% of the municipalities in Brazil, most of them small municipalities of 20,000 inhabitants. Most of them, 80% of them, have students enrolled in our initiatives at this point. And just to give to you, those are the division of the country by municipalities. Most of the municipalities have the number of the enrollees in each university that comes to the system and have educational activities in the system of the open university. And to finalize, I think that the founder of the reform of the health system in Brazil used it to tell, I think that's quite important for us, that health reform in Brazil is a process of building citizenship and developing our civilization, more than being just a technical matter. So if we in Brazil do not agree with basic basket of services, we do not agree with universal health coverage that's just expanding the package of services, but we think that the social determinants of health, we think that the idea of having health present in all policies is quite important. And for us to leave the citizens at their own for search for health services is barbaric. When we are developing our health system, we are thinking about civilization and we are thinking about citizenship in our country.
Thank you, Professor Campos. It's really unique to hear from you. Unique, the system you are developing. This is a country, multiple similarities, size, population density, inequalities, social and economic imbalances, geographical obstacles, much alike situation in India, but you have been successfully developed public health education system, an alternative mode where you are really training and building up competencies in dealing with public health problems, disease control activities. And it's really very unique to see that the very magnitude of educational resources, IT-based resources you have developed already. The videos, the multimedia, those are, and this is open access. This is open access, that is, all the enrollees can access these resources, I think, free of cost. It's free of cost. It's a really unique system, exemplary situation. Thank you for your excellent presentation and the information we got. I will now request Professor Hawk to hand over the certificate to Professor Campos.
Please hand over the certificate of appreciation.
Thank you, sir.
I have two decisions for
Salute is presently the Senior Advisor, Health System Support Unit, Public Health Foundation of India. He started his career as Faculty of Community Medicine. He was also acting adjunct Associate Professor of Biological Sciences, Human Ecology at the University of Texas, USA, School of Public Health from 1994 to 2000. His 30 years experience in public health departments spans from Deputy Director to Director General of the Health Services of Maharashtra, the leading state in India in the domain of public health. He has assisted the state government to initiate a number of schemes such as Jivandayi Arogya Yojana, free blood supply to the thalassemia patients, monitoring medical care in trust hospitals for poor, etc., mainly focusing on health services to the poorest section of the society. He was one of the members of designing National AIDS Control Program Phase 2 during 1999-2000. That was a major step in control of HIV/AIDS through the National Program for the Control of HIV/AIDS. Dr. Salunke had defined position during the stint at WHO CRO. He was Assistant Regional Director, WHO Country Representative, To Indonesia, Regional Advisor for Emergency and Humanitarian Action and Regional Advisor Communicable Disease Surveillance. He has a number of publications in national and international journals. I now invite Professor Salvike to come to the stage for speaking a few words on developing public health cadre in the states of India. Dr. Salvike.
Thank you very much for the introduction, and I at the outset wish to thank the organizers and you, Professor, for giving me an opportunity to make this presentation. Friends, on the presentation since morning, you have seen, also been given these different statistics. I feel we have earlier presentation by is a clear indication that in spite of resource constraints and in spite of so-called mid-income countries, how public health can be organized and how it is possible for any country to design the public health system which will address the challenges faced by the country. I think what it requires is enlightened governance. What it requires is enlightened politicians. What it requires enlightened bureaucracy. And these are the teamworks which are demonstrated in a country like Brazil. There is a lot we have to learn from a country like Brazil. What we have, one of the major issues that we are facing in this country is, I don't think that this audience requires to go into definition of public health, you have already heard of. What are the major public health challenges that we are facing? Skilled staff shortage is well known. Our referral systems are practically in the rural areas practically not functioning. Health system or healthcare delivery system is qualitatively in India called defined something like poor service delivery system exists in India. Our logistics management till very recently, till the NRHM took shape, this was non-existent, but now it has started some sort of a mechanisms exist. And the most important challenge that we have is the lack of accountability in the quality of care, both in public sector and particularly in private sector. There is no legislation at this juncture by which we can assure the quality of care in the country. And health sector reforms are being considered as something which are okay, as and when it happens, it will happen. The public health functions that have been enumerated here, most of you are aware about that, and I'm not going to go through the list. The only point that I'm trying to indicate to you that the perception of the decision makers in the country at this juncture, some of the very senior bureaucrats interacted during some of the meetings, have said, what is the public health? Anybody can monitor, anybody can do it. The same bureaucrat never accepted that anesthesia can be given by an orthopedic surgeon and ENT surgery can be done by an ophthalmologist. That he should know, it can't be done. But public health can be done by anyone. I have had an occasion to witness a situation wherein within a span of a couple of months, a senior bureaucrat in Delhi said that I am now public health expert. Now the point remains, we have to appreciate that public health is a speciality. Public health requires basic training of public health, not only for doctors but for non-doctors need to be trained so that they can become trained public health professionals, which is the need of the day. As you are aware, as of today, that entire health system that exists in the country, in India, is based on the Board Committee's report of 1946. We have right from periphery to the top, sub-centers, primary health center, subsidiary health center, or community health center, district hospital, state machinery or state mechanism, and the central mechanism. Now the entire public health in India is based upon the hierarchical system. The government of India is expected to give two things: technical advice and resources. Health is a state subject. That means the states are in the driving seat and they are expected to lead the community and the states in the directions of achieving whatever the goals that we set. Government of India has a role, particularly in the concurrent list, which includes medical education and related issues. However, the National Health Policy of 1983 and 2002 and earlier reports, and I don't know how many of you have had an opportunity to access the proposed National Health Policy 2015. It's on public domain now for commenting. Now that public health, National Health Policy also brings out the issue that what you require is for delivering the public health related activities in the country, you require professionals trained in public health. That is bottom line as far as these various reports are concerned. This is also reiterated by National Knowledge Commission, the high-level expert group appointed by Planning Commission, and steering group or steering committee on 12th five-year plan. As a matter of fact, if you read the recommendations of 12th five-year plan, it clearly brings out, at least on 3 paragraphs, that there is an urgent real need of dedicated public health cadre with support system comprising of epidemiologists, entomologists, public health nurses, inspectors, etc. etc. So please remember that the various expert committees are focusing on public health professional development in the country, not only for doctors. Today, primarily the public health management in the country is focused on doctor-centric, while the real approach is along with the doctor or what is multidisciplinary team approach. And this has been reiterated again and again by various committees. So what happened in 2012? The Government of India, after a lot of our persuasion and a lot of our discussion, appointed a task force. And I was one of the coordinator for this task force. And we prepared, there were 2 task forces. One was related to public health cadre development and other was related to Model Public Health Act to be drafted. And these 2 task forces met for about 1 year and we gave the recommendations and the report to Government of India and it was accepted by June 2012. Based on these reports, 4 states accepted the challenge and they said that okay, we want to experiment with the developing public health cadre in the respective states. And accordingly, the Odisha is now going to be one of the leading states which is at the stage of really getting government approval for developing public health cadre in the state, and we have to complement this state. The guiding principles that we used for the public health cadre development was that the states are in the driving seat. Government of India or any other agency cannot dictate, cannot direct, cannot authoritatively say that thou shalt do this. It is left to the wisdom and discretion of the state governments. And that should be, during this entire phase of developing public health cadre, minimal restructuring and disruption needs to be carried out. Otherwise, no state is going to accept the public health cadre creation as such. States will have to utilize the existing HR. We cannot expect that the state will develop totally a new HR and incur by a lot of expenditure by creation of additional positions. As you know, the financial situation at the country level and at the state level is never very happy situation. No state is in position to say that, oh, we will create a lot of positions. That doesn't happen. If there is any proposal which comes out from any committee, say that you have to create X number of positions, that proposal is promptly rejected by the government, particularly the Department of Finance, because they don't have money. Many states are absolutely indebted. There are states who say that we don't have money to pay for the salary. So the moment you talk about creation of additional positions, that is not going to be accepted. Now PHC cadre development should focus upon, as I said, multidisciplinary approach involving other sectors. Please remember, all of you, those who work in the field, will realize that zoonotic diseases are one of the major challenges that we are facing. Is there any relevance in the entire public health system in the country as of today, where the doctors of veterinary sciences or other professionals of veterinary sciences are ever related to public health? Is there any state in the country? Absolutely not. And that is one of the major things that we have to consider, that whether it is water sanitation, whether it is the animal health, social sciences, management, entomology, etc., etc. Public health is much broader than only medical sciences. And that's the reason when you want to develop a public health cadre in the state, you have to focus on multidisciplinary approach by involving other sectors. This is the key principles that we have to consider was, from where do we develop this public health cadre? Should we develop right from the periphery, primary health center, on the block level, or at the district level? We left it to we felt that the state will have to decide whether for block or primary health center. But we recommended that if you cover block, the districts and the state level, that will be something resolving the issues. To do this, what we will have to do it, the state will have to design a small technical resource group at the directorate level, at the government level, and this will have to carry out the review of existing cadres within the doctors or non-doctors, both in the rural and urban area. I think friends, please remember, urban health is one of the major challenges that we are facing. There is no formal infrastructure throughout the country excepting few municipal corporations, whether it's at Delhi or Calcutta or Mumbai under IPP5, World Bank assisted, or any other sources. Otherwise, urban health is one of the most neglected areas. Outbreaks are taking place. The system doesn't function. There are no surveillance or mechanisms that exist today are being controlled by both the Directorate of Health Services to a certain extent and nothing beyond that. So I think public health cadre needs to be developed not only for rural area but also in urban area. I hope you are aware of the fact that there are some states like Tamil Nadu and Maharashtra. Tamil Nadu is already reaching near 50% of the urban population. Maharashtra is also around 46-47%. Like these states are going to face major challenges. So public health cadre development has to be both urban and rural oriented. You are now taking into consideration what kind of job charts are there, how do we modify these job charts. All these issues will have to be addressed right from the periphery to the state level. We will have to then design intersectionality. We will have to also take into consideration that the clinicians are the part of the health system will have to be given equal opportunities for promotional avenues, for career development, because whether we want or not, clinical care is an integral part of the work. There are a large number of institutions which are available to train public health people, and these are the sort of an action plans that we have indicated to the state to how to deal with this. And thus, I feel what is needed is also to issue the issues that also will have to be addressed. Some people say that some states are having no primary public health cadre, still they do a good job. So why do we require public health cadre? This has to be addressed, that public health cadre development is not the only solution. There are multifactorial in nature, and that's the reason if a state is doing a good job and you have a public health cadre, they do better than what they are doing. There are going to be some financial implications that we cannot afford to ignore, and they have to be committed by the state. There will be resistance from clinical cadre. People who are right now ophthalmic surgeon dealing with RCH, he is saying, why can't I do? What's the problem? I have seen in one of the states where the person is having his own nursing home and he is a very successful orthopedic surgeon and deals with RCH. He is district level officer of RCH. I said, my dear friend, you can deal with your clinical part. He said, but I can also deal with RCH. Why not? The point is that if he wants to deal with this, let him undergo a training program. Nothing beyond that. Nothing. Principle is simple. You should be trained to do a particular undertake a particular responsibility. Simple principles. There will be then we will certainly feel that assistance from Government of India is must, and the Government of India also has a challenge, because when I made this presentation to the health secretary, they said, what about Government of India? Are there public health cadres in Government of India? And the answer is, there is a very limited public health cadre or public health specialist in Government of India. We felt that Government of India, these functions also require sufficient number of public health trained people in Government of India. This is the present structure of Government of India in India, and we also felt that the Directorate General of Health Services and Government of India can be divided into two DGs. One will be focusing on DGHS medical, and the other one is supposed to be focusing on public health. And this DG has to be coming from the sort of a hierarchy by which a DG is trained in public health. He is the one who leads the country as far as public health programs are concerned. And this is something, final slide, this is something which we said that there will be Minister, there will be Secretary Health and Family Welfare, two DGs, and all the additional DGs and DDGs who are dealing with the national program can be a part of this entire thing. So the public health cadre need not be restricted only to the states. Public health cadre can be developed and needs to be developed at the national level also. Thank you.
Public health, and in his presentation, the interesting thing is he has a vast experience in public health, not only in India but also in regional countries, and of course overseas, having international experiences also apart from the Southeast Asia region. And I was very much close to him also when we were working in Seattle and he was in different country offices. So what he was mentioning about public health care, some propositions and proposals or recommendations are there for India, and I am sure and I have all confidence of him that is based on his experiences. So I fully endorse that as a chairperson here, and also I shall be very happy if this can be. And next thing, he was also mentioning about public health, a multidisciplinary team approach. I think none can deny that. As well as he was also mentioning about clinical care, an integral part of public health. So I think none of us should forget that. And training of public health cadre and establishment of a cadre, and then putting them in a role where they can play best, or they can, with of course proper regulation. With that, I think we must thank again with a big thank you. Capacity development. He is also the sub-dean for postgraduate examinations in the School of Medicine. During the last 7 years, he has been collaborating with the Public Health Foundation of India to a welcome trust funded on the research capacity building as a part of consortium of UK universities. Through his project, he has been involved in developing a comprehensive framework for public health education with a focus on India. In his presentation, he will outline the concept, justification and processes involved in developing this comprehensive framework for public health education in India. We will hear from Dr. Ricky on public health education, developing a competency-based approach for India. Dr. Ricky,
I hope I don't get you too bored, but what I would like to do is actually provide you with an appetizer before lunch. What I'm going to do is try and build links between the previous three speakers. Professor Zorpi discussed the international trends, particularly the recommendations from the Lancet report towards what global public health education should look like. And one of the key messages coming out of that is around developing a competency-based framework for public health education. So what I'm going to talk about is really what that means for India, and also to give you a little taste of some of the work that I've been involved in with colleagues at the Public Foundation of India in terms of developing a competency-based approach to public health education. So what I would like to do is discuss with you why a competency-based approach is important for India. Outline the initial process of developing a competency-based approach for public health education and share some of the findings that has come up as a result of this work and what are some of the next steps. As you would appreciate, developing a competency approach for a country as large as India, where, as Dr. Salanke had identified, that public health cadre is one which is still developing, is something that will take some time. And during our discussions at tea, we were discussing the need for a parallel development of a competency-based approach along with a cadre of public health professionals and public health workers in the country. We need to start with a cohort of like-minded individuals who recognize the need for a public health cadre, a public health speciality, and within that public health speciality, different levels within public health as well. There are a number of different examples globally in terms of different approaches for developing public health, and we recognize that you can have at the very top level a very medicalized professional type of public health approach, whereas at different levels within the organization, the health system that is, you can have a number of different public health professionals, and these can include people who are working in environmental health, people who are working in health policy, people who are working in health financing, people who are working in human resources. So it is essential to recognize that public health is very much a multidisciplinary function, and it requires that set of skills, knowledge, and attitudes which are multidisciplinary. So I'll first start off with what is competencies. Professor Zorbi talked about competencies, and I'm going to tell you more about what that means. It is very much a process of developing public health staff, their knowledge, their skills, and their attitudes. So it's about developing these three to meet the needs of the public health system, to meet the current needs of the public health system. In addition, it also needs to address the existing public health challenges. So it's twofold, not just public health challenges, but also the needs within the public health system. That is, what kind of leadership needs there are in terms of developing policies and plans. What needs are there in informing the financing of public health? What needs are there in terms of the development of human resources, in terms of information systems, in terms of technology, and in terms of supplies and infrastructure. So there are those two current needs within the health system. The challenges as well as the health system needs are those things that a public health professional, a public health worker needs to know and be able to do. It also has a futuristic approach to it as well. Competencies in public health is not only about being able to deal with the existing public health challenges and the existing health systems challenges, public health systems challenges within the country, but it is also about being able to look into the future and plan for the future. It is about being able to respond to the future challenges within the public health system, as well as to be able to plan for and to respond to future public health problems within the country. So that is very much what a competency-based approach to public health is, being able to address the public health challenges now and being able to address the public health challenges in the future. By looking at a framework which develops a set of knowledge, skills, and attitudes within staff for public health systems, and public health intervention, the theory is that we will be able to perform much better, that we will have staff who are much more motivated because they're responding to the needs that they know exist. If that happens, then hopefully in theory what we would see is a positive effect on health status. So there is a real benefit in terms of having a competency-based driven approach to public health education. These challenges are very much linked to a set of complexities that exist within the public health system. Within the public health system, any public health system, and particularly the public health system in India, recognize that the system, that is the public health system, and its external environment is constantly changing. It is not a static thing. People are moving into the system, people move out of the system as a result of moving in and out of the environment as well. We have different public health challenges and very different problems that people face. Individuals within the system also range from followers to very dynamic leaders. So within one public health system, you have a wide variety of different skills and knowledge that exist within the public health workforce as it is. And we need to develop, to hone in on those that exist, but then to develop them based on an ability to respond to the current challenges and the future challenges of the public health system. There are, however, some uncertainty that is inherent in the system. We're not always sure what changes are going to take place. So we need to have those skills that demonstrate a level of flexibility within the system. Small changes within the system can have very positive impact, big impact. It could have positive impact, it could have negative impact. A change in the decision to move from one way of working to another way of working can have potentially a devastating change in terms of how all human resources within a state can work. Similarly, one small cut in one area of a budget can have a potential detrimental impact in terms of access to services that people will have. So, recognizing that change, even small change, could have both a positive impact or large negative impact is something that needs to be taken into consideration. Change is more easily adapted when it is owned within the system and becomes the norm. And I think this is one of the things, again, looking at a public health professional cadre or a cadre of public health professionals, if they internalize a set of competencies and they are the ones who say, this is what we want, there is greater acceptability, and with that greater acceptability, potentially better outcomes in terms of services, and by extension, better outcomes in terms of impact on health status. One of the key things that we also recognize about public health is that problems can be localized while you may have a specific situation and outbreak in one small area in a country. That can have an impact not only there, but possibly in terms of a district, state, national and cross-border impacts. So being able to understand these challenges and complexities within the health system is something that demonstrates what a curriculum in public health would need to have. When thinking about competencies in public health, that is, a competency-based approach in public health, one of the things that also came out of the Lancet Commission is around the modalities of teaching and how teaching will change. Professor Sorfi said that 30% of what we teach is redundant and 70% of how we teach is also redundant. What does that mean? What does that mean in terms of a competency-based approach for teaching? I am a public health teacher. I enjoy teaching public health, and as part of that, I've seen my journey as a public health teacher change and transformed. In a traditional form of education, we recognize that knowledge is static, finite, linear, and probably in some countries privately provided. One of the speakers before demonstrated that, and that's my colleague from Brazil, showed where now material is not necessarily built on text, that there is a number of different forms of material. For a competency-based approach, it recognizes that knowledge is more dynamic, it is open-ended, multidimensional, and should be provided through a public health system, a public health education system. That is, material in itself doesn't necessarily have to be only text. It can include videos, case studies, games. Last week, I spent the week in Bhubaneswar with colleagues from the Public Health Foundation, teachers in public health, working on how to develop case study methodologies in teaching and assessment. And at the end of the week, colleagues were able to develop 9 specific outputs. Cases, Indian-centric cases, that is, cases that are specific to India, for them to do their public health teaching. Also, to do assessment. So they were able to develop the cases out of a week and build them into a teaching session and forms of assessment, not just exam-based, but presentations, developing of videos, developing of posters, and all of these using the case method approach of teaching. So very dynamic, very enjoyable, not only for staff, but potentially for students. And I think this is one of the things that is further on in developing and checking. Do students really enjoy a less didactic approach to teaching, and do they enjoy one when knowledge is much more dynamic and open-ended? For staff, what was really important here is that these 9 cases was something that they were willing and open to sharing. It wasn't developed by one individual or a group of individuals with their hallmark on it, but it was open. And at the end of the week, one of the things that we were able to get from people is that willingness to share material as well. In a more traditional environment for learning and teaching, learning is very much instructive, top-down. In a competency-driven approach, learning is much more constructive. Concepts are acquired and built and modified. So it's not just about giving a definition and this is fixed. It is about being able to work together to come up with an understanding of how things work and recognizing that that changes as the environment changes as well. So that a public health professional, a public health worker, understands that a concept, whether that concept is a health systems concept or health intervention concept, that that concept changes, and it could change depending on the environment within which you're working in India as well. A traditional approach to teaching sees the teacher on stage. One of the things that I like to say about myself is that sometimes I feel like an actor, but I'm here and I'm giving a performance. That has dwindled, and what is happening now is that teaching is much more of a facilitation, that the teacher is on the side and that the student is the one who is at the center. In public health, if we're developing students and developing people who are already within the system, they come with a set of experience, they come with knowledge of the system, and they can tell you much more in terms of what the problems are, what the causes of the problems are, and together work towards solutions within a theoretical framework. And that really makes teaching very different, because it makes teaching one which is guided rather than instructive. Assessment, in a traditional sense, looks at assessing based on the information that has been provided in a class, whereas in a competency-based driven approach, assessment is based on analysis, synthesis, and personal development. So what a teacher would be looking for is that a student, a public health student, can take concepts that have been developed and understood, apply those concepts to problems, and recognize mechanisms towards addressing those and limitations that there might also be in terms of addressing, because you're not going to solve all public health challenges in one go, and there is that need to recognize that. The curriculum in a traditional setting is one which is more historical, and students are told that this is what you have to learn, whereas within a curriculum, through a competency-based approach, students are also engaged in the learning process. They are engaged in supporting what the curriculum says, and what the curriculum should outline. Quality assurance in terms of ensuring quality of teaching processes in a traditional sense is one which could very easily be a paper exercise, whereas in a competency-driven approach, it is very much for the teacher an ongoing process, and one which is used to support learning, and one which is used to encourage the teacher to develop. Evaluation, finally, is one where in a traditional form of training and education, the teacher focuses on evaluation, whereas in a competency-based approach, evaluation is much more learner-focused. That is, it focuses on what the learners need to learn, and that need is very much based on what was identified very much at the beginning. Those problems that exist in the system, those public health challenges, and those health system challenges now and in the future. So if we're evaluating, we want to know, have we been able to address problems in the public health system? Have we been able to address the health problems in the system as well? So these points demonstrate how traditional teaching changes into a more dynamic form of teaching when looking at a competency-based driven approach for teaching. I want to talk to you now about the experiences that we've been involved in terms of developing a competency approach and the initial stages of developing a competency approach for public health education in India. And this is where the first action that took place in 2013, June 2013. It seems like only yesterday, but it is about a year and a half, a little more, almost 2 years now, where we had this first workshop on a competency framework for public health education. In that, we went through a process of trying to bring together a set of staff from the Public Health Institute PHFI of India, and this is funded through a program funded by the Wellcome Trust Foundation, and this program is a program on capacity building for the PHFI, and it includes, as Dr. Zorbi had said earlier, 14 UK universities, one of which is the University of Leeds. This workshop was facilitated by two colleagues within the consortium, one from the UK Faculty of Public Health and myself from the University of Leeds, and involved staff from the various institutes from the Public Health Foundation as well as the head office in Delhi. Members of staff demonstrated in the picture before all have experience either teaching in public health programs and or have worked within the public health system in India. So they came with knowledge about the public health system in India. And what we did is we went through a set of exercises to come up with a set of competencies which are specific to India. One of the things that Dr. Zorbi said is that what is not needed is a cut and paste from the Lancet report. So what does that mean? It's very easy to take an international report and say, well, this is something that can be applied to all countries. And what they recognize is that a problem, a health system problem in one country is very different from a health system problem in another country. In a country as large as India, a health system problem in one state is completely different from a health system problem in another state. So we decided that what we would do is define what these competencies within a public health education system would be specific to it. So the first exercise was to think about, well, what are the public health challenges for India? And we had a list of them seen before, and very much some of those were identified. However, people might be able to identify other things which they have seen and weren't seen as priorities before. We also looked at the function of public health professionals at different levels within the public health system. So what the functions that different individuals who work within the system do. And from my experience of teaching in a Masters in Public Health in the UK, when our students come back to us and they said, when I've gone into a job, one of the things that I recognize is that I don't only need to know how to respond to a public health challenge, but I needed to know how to respond to human resource problems. I spend most of my time as a district medical officer dealing with human resource issues or dealing with financing issues. And those are the things that I really needed to learn in a Master's in Public Health, or those are the things that I really needed to learn in a diploma. So we looked at the different functions that a public health worker would deal with and try to categorize them based on different levels. Then identify the skills, knowledge, and the attitudes that would be needed to deliver those functions that we looked at and to address the challenges. then finally out of that, and it took us to develop, to identify what skills, knowledge and attitudes. That took some time. That took us at least a good 2 days of work and debate and discussions, but very well worth it. At the end of that, what we're able to do is to develop a set of learning objectives which are really specific to India. So that what we were coming out with is a product that says these are the things that a student needs to learn to be able to be adequate, to be a potential, to be an effective public health worker in India. So I will share with you some of the findings. It is quite a very long, extensive list. I have to share all of it. So what I'll do is just sort of give you the key points in terms of it. The public health functions, and this is a list of the different public health functions, and it very much mimics a list that you might have seen before. However, these were coming from the bottom up, not from the top down. This is not what government is saying or what someone from outside is saying that you need. This is what people who teach and work within the public health system will say. These are the challenges, the functions that public health workers are involved in. And what I've decided to do is only to take just one of them, responding to public health emergencies, and explain to you some of the things, the findings that we got from those. So in terms of knowledge, if you want to be able to respond to public health emergencies, the type of knowledge that a public health worker will need would include knowledge of public health emergencies, disasters that a particular area are prone to. They would need to know about disaster preparedness, how to plan for disaster mitigation, post-disasters, and how to capture knowledge as a result of disasters. They also need to know who different stakeholders are within a disaster response, and they need to know where resources are available. Not just financial resources, but human resources, technical resources, all the different types of resources. A public health worker needs to know where those exist and at what cost they might exist as well. They need to know about disaster management models. What are the different approaches to managing disasters? And they also need to know success and failure stories of disaster management, not only in India, but also in the world. Now, there is a full list of knowledge areas in terms of someone who is required to respond to a public health emergency. What does this mean then for education? How does that knowledge translate into a course? For a module or a session in community medicine, we can take one. You don't need to use all of them. For a diploma in public health, and for someone who will end up working in the mid-levels of public health, you may take some of them. For someone who is doing a master's in public health and will become a leader in public health management, they need to have all. So this is how this competency-based approach is designed to work. You can pick and choose those areas of knowledge that you want for your program, to develop your curriculum, depending on what the program is and where the graduate from the program will be working. So those are just the knowledge areas. In terms of the skills responding to public health emergencies, the skills required by public health practitioners include being able to assess the emergency. Straight after an emergency, you need to understand and to assess damage. So that is a skill in itself. They need to analyze the situation. They need to predict unforeseen scenarios. They need to prepare plans. They need to have planning skills. They need to know how to set objectives. They need to know how to budget it. They need to know how to monitor a plan, how to collect information, how to communicate information to those who need the information so that they could respond to the needs of the people on the ground. They need to review current models of disaster management. They need to respond to disaster emergencies, both from a preventive point in terms of reducing the impact of disasters. So if we know, for example, that a cyclone is approaching, by having an early warning system and an early warning system that works, we could move people away as quickly as possible so that you reduce the number of deaths and disabilities as a result of a cyclone. Post-disaster rehabilitation, you also need to recognize that as a public health practitioner, there are issues that need to follow up. So for example, post-cyclone, you may have to deal with outbreak of vector-borne diseases. You would have to probably deal with cholera outbreaks. So there are different types of skills that are needed to respond to either mitigating of the disaster on one hand or the rehabilitation phase of a disaster. Again, other skills include drawing comparisons between different models of disaster planning, being able to do rapid needs assessment, which is very similar to assessing of emergencies. However, one of the key skills is being able to communicate and coordinate. One of the things that we recognize in newspapers as a result of disasters is the issues around coordination. Disaster response is one which is multi-sectoral in approach, and very often than not, public health agencies are the ones which have that coordinating responsibility. So these skills are a list of the different types of skills that a public health professional or public health worker will require. Again, like the knowledge area, not all of them will be required in a course in community medicine, in a school of medicine. Some of them would be required in a diploma in public health, all of them very much in a master's in public health, and for one who is going to be moving towards a public health leadership role. I've not included any of the attitudes in terms of what we developed, but what we did is that we recognized that as we were going through each of the different functions, we recognized that the attitudes for public health workers were cross-cutting and very much the same. And one of the key attitudes in public health is that of equity. That a public health worker needs to recognize the concept of equity and to be able to respond in its development of interventions and development of public health systems in an equitable way. And what does that mean? If you're going to allocate human resources within your public health system, you need to be able to allocate human resources where the public health need is greatest. And if the public health need in your state is greatest in urban areas, then that's where the majority of your public health workers need to go. And that kind of thinking is a very much an equitable concept. And that takes time to develop. That's not something that attitudes in public health change very often. We as individuals, our attitudes are shaped by the environment within which were brought up by the circumstance under which we have been educated. Working in public health challenges that at every step of the way. It constantly challenges me, and I'm sure for all of you here as well, it is a challenge to think, how do you address equity? Because equity is not about all for the same. Equity is really about where need lies. Is it in an urban area versus a rural area? Is it the young versus the poor? Is it men versus women? So equity is that one of the key values that we discussed in terms of ensuring public health. What that relates to in terms of a curriculum is ensuring that when students are engaged in assessment and discussion, that they are talking about equity, that they recognize that when they move into the field, any decision they make has an impact. That little decision that they make could have a big positive impact or a big negative impact. And that is really very much based on that principle of equity. So what does this mean in terms of the way forward? We ended up with an extensive list of different areas of knowledge and skills for each of these. The next steps are around testing and taking these lists of competencies even further and taking them out into the field and getting them verified. Because working with a small group of still very much public health educators is not specific enough, and we feel that dealing with and getting the input, greater input of public health, existing public health cadre is essential to taking these competencies even further. The dream is, and this is very much a dream at this stage, is to develop a user-friendly document or framework which can be used for various levels of education and areas of public health education in India. So as I've discussed, a living document, one which is flexible enough so that a teacher in community medicine at a university could say, I can pick and choose, or someone in human resources can say, I want to develop a program on human resources for public health, or someone can develop a complete program on disaster response for public health, or looking at a full master's in public health which could incorporate many of different skills, knowledge and attitudes among the different functions in public health. So while we dream, and this dream has to happen in parallel with the development of a public health cadre. It can't happen, this can't happen first, and then a public health cadre. I think it is essential that a public health cadre, a public health profession, and a line of public health professionals needs to be developed in conjunction with a set of competency-based approach for public health education in India. In the meantime, colleagues in PHFI are using the framework that we have done in terms of developing their programs, their diploma programs, and the linkages with masters in public health that they're working on. And then finally, building public health in India, along with a appropriate staff. And I think that's the last and most important point. If we're going to develop a set of competencies in public health teaching, that this is built along with the public health cadre within the company. That's it for me. Thank you very much for listening, and I hope I haven't taken you too far away from your lunch break.
also mentioned about teaching learning strategy or educational strategy for a competency-based curriculum, and which he wants that it should be outcome-based learning. That's in brief he wanted to actually tell, wanted to actually tell us. And also he has mentioned about what next to be done in India. And with that, I think once again congratulate you. Thank you very much. Thank you.
I call upon Professor Hong to hand over the certificate of appreciation to Professor Kalsar. Another area for which he is taking interest and now promoting the team as a task force member of GCSA, that is Global Consensus on Social Accountability. Public health education, accreditation of public health and environmental health are the areas of his keen interest. As specialist and process expert, he is the current chairman of Public Health Foundation of Bangladesh. Professor Hawk will be speaking on accreditation of public health education focus criteria.
Thank you, Mr. Kaushik. The previous speakers has made my task very easy because they have covered almost everything, even some of the focus criteria of accreditation. So, Mr. Chairman, ladies and gentlemen, very good afternoon. So, accreditation, and I think all of us are quite aware of what it means by accreditation. So I am not going into that, but there will be a slide where a simple definition of accreditation will be made so that we can make ourselves aware. So when I shall be talking on accreditation, as I said, my previous speakers starting from the objective to evaluation of all part curriculum, all of the curriculum has been completed. And when I talk about focus criteria, and then also again there will be some repetitions, please forgive me for that. So when I was being introduced, I think there was a term used, social accountability. So when I think about accreditation, I think in my heart and mind that there should be some accountability of public health. I mean public health education, public health service, as well as public health research. Actually, we are doing it. So, if we are doing it for our common people or general people, then there should be some sort of accountability of public health education, public health research, and public health service to those people. When I say accountability, then there should be some responsibility to it. So, my accreditation is actually in line with or in accordance with social responsibility as well as social accountability. So let us all keep that in our mind, that we have some responsibility to the society when we talk about public health. And I'm sure that this, unless and until we have a responsibility, we shall not be doing anything. And if we are not accountable, then the responsibility will be, I think, not a committed responsibility. So when I say accreditation, it's nothing but a process where an agency grants recognition to an institute for demonstrable ability to meet predetermined criteria. That is why I shall be bringing you in on a focus criteria. So now let us see, as there should be some predetermined criteria and demonstrable ability. So let us also keep that also in our mind when we will be going through the presentation. So focus consideration. Before we go through the focus criteria, so what should be focused actually for our consideration? So there I bring in accountability of public health education. Who is accountable for that? And then the role of the accrediting body. And we all know that still now, not like medical council, there is an accrediting body for public health education foreign institutions in our region. So that is a big question still being raised by even WHO, that who will activate. And we have also, WHO has developed also their accreditation method, but still in papers. Then on any education of health science, we have to take into consideration the World Federation of Medical Education standard. So when we talk about health science education criteria or medical education criteria, there is an organization where I belong to. Also, they have a standard. And you were listening to the presentation of Professor Vicky also, where he was mentioning about quality. So all these are the focus consideration for a focus testing. Now, this is a copy of one of the presentation that was made by Bob Miller of Canada and on social equity. Now, if you look at the slide, you see the way we conceptualize. How do we conceptualize our public health graduates or medical graduates with public health education? Do we conceptualize properly that what shall be their duty or what will be their responsibility and where they are accountable? Do we take into consideration when we are conceptualizing a graduate coming out from the medical college with community medicine department teaching and learning, and even after that, those who are in the Institute of Competence? That is one thing that we are thinking first, that how do we conceptualize? Then, are we producing as we conceptualize? So we conceptualize our graduates to be brilliant. We conceptualize our graduates to be empathetic. We conceptualize our graduates to be competent. All this we conceptualize. But when we are producing, do we keep that in our mind? So that is again the thing I think when we are producing from our institutes. Then already we have produced. How about the usability? Society, when they are actually using them, all the bodies, those who are actually using them, do they get the product as the institution has conceptualized or the society was expecting? So this conceptualization followed by the production and usability of those graduates or public health specialists, whether they are usable in the society. When I say usability, it is private and public both. So that we must be the part of it when we think about an accreditation. We have listened to Professor Vicky about public health competencies. So, with due respect to all these detailed competencies, I am bringing them into four. All those will be covered there. If we say management competencies, there are management, different aspects of management, leadership competencies, teaching competencies. When we talk about a doctor, the meaning of doctor is itself is doctor, I mean teacher. So teaching competency of all graduates, I think they must have competency of teaching. And teaching there are different aspects of it. I am not going into detail on that. Research competency. So these four competencies, if I say, we can break them into different other sub-competencies. So these magic competencies and core competencies that must be developed in when we think about the accreditation, I think this should be brought into consideration. When you talk about curriculum, and we have discussed about competency-based curriculum, outcome-based learning in our last presentation. And then when we talk about the core curriculum again, as I was mentioning, the core competencies. So what should be the core curriculum? And that detail we have seen in my previous presentations. But when we talk about core in the public health competency, there will be epidemiology, biostatistics, resource matters, environmental health, public health laws, health planning and management, population science, health information management. Of course, nobody of us can know the clinical management of diseases, but there we should take care of history of the disease. If you look at the additional curriculum, I'm taking this into consideration in our public health curriculum. Maternal child health program is done. And if we are taking what actually we are teaching of maternal health child health, most of the part of the people, not of the clinical aspect, much of it. So, same with the nutrition, occupational science, health system, disaster preparedness. Yeah, disaster preparedness, policy analysis, I think all these has been taken care of by my previous speaker. So let us break it into two, the core and the additional. If we can do that, we can even distribute that how much of these students or the graduates should be learning by themselves or taking what method they will be learning. We know about educational development that after the Christmas people that lots of developments have been taken. But the 21st century challenge is different. Now the challenge is not that scientific education or effective creation of decisions, rather improving quality, tweaking, relevance and effectiveness. That is where social accountability comes in. That unless until we are improving the quality of education and service, equitable service, we cannot ensure, and the relevancy of the education with the need and the effectiveness of education, we cannot think of as effective public health service or in the term of conserving the public health functions that you expect actually to be delivered. This is a simple right to health care of individual and society. Now you see all these four things has come: quality, equity, relevance and effectiveness. You can just go through it. So relevancy, that is where actually the question comes of priority and needs. So what is the priority of the society? Or what is the priority health needs? Are we taking care of that? Or if we are taking care of that, whether we are effectively taking care of that by utilizing our doctors and others. So that is where all this should be taken care of when you think about a functional public health system. This is a quality cascade. As a teacher, I think we should keep that in mind that ultimately what we want is nothing but a quality health care. And who doesn't want that? Even the community, society wants that. A quality health care. And for quality health care, we need a functional, effective health system. Without a functional, effective health system, you cannot provide quality health care. And for that, you need competent health workforce where public health is growing. And then, for a training quality, training, you need a quality program or a curriculum, enabling teaching, learning environment, and competent and committed faculty. Now we can question ourselves that whether we have sufficient, competent, committed faculty. That is number one. Then whether we have a teaching learning environment which enables learning. Whether we have that, and of course, whether the program or the curriculum is need-based or competency-based. These also and then we have to take care of the priority health needs of the community of the society. What society expects? Society not only expects quality health care, but the society also knows that quality health care only can be provided by competent health workers. So this quality cascade, we should always keep it in our mind. Say, if you can take up enabling teaching learning environment, this competent health workforce will not be good. You take up a quality program, whether you have a competent faculty or enabling learning and teaching learning environment. If the program is not well articulated, need-based or
competency based, it will not ultimately provide a positive platform for that particular. Now, these were discussed for a long time, and again I bring it again here that the curriculum and the teaching learning method, the institution and community-based science, I mean the campus and community partnership. Okay. So for the professional competency, these are a must. So if you have a good curriculum and a teaching learning environment, and then there should be strong partnership. That is again an enabling environment for public health. That is a campus and the community partnership. I mean the institution or the university and the community. So how strong that partnership is. So public health learning will be better if it is there. I will be showing you some other slides which also say that this is a must. And social accountability and accreditation is related again with quality education and quality practice. That is, an accrediting bodies to ensure. And that can be done by setting and monitoring standards, issuing guidance to support implementation of standards. And that is what every accrediting body does, including the councils. Take care of the standards. 9 areas where World Federation for Medical Education has actually focused for their accreditation. And they have set standards. What are those 9 areas? If you look at the slide, I think my previous speakers has already covered all because here everything is there. But the problem is the student selection. That is one thing. That is sometimes you don't take care of. So some of the institutes, I can mention about one institute in Nepal, they have started already selecting students in a different way than usually normally. So this World Federation for Medical Standard will be a binding very soon for all the countries of this region. And I think we are working on it, that how this can be accredited by World Federation. The accrediting body in countries can be accredited by World Federation for Medical Education. So negotiation will be started very soon. So again I come back to the conceptualization, production and needs of the society. So now we know the quite knowledgeable. Did we ever thought of using the established GPs as an adjunct faculty or a faculty from the institute, or placing the students under them? Did we take literate teachers interested in teaching into the institutes or as an adjunct faculty or utilize them? We can think of. There are many NGOs like Public Health Foundation of India. We can say this is a non-government organization. GP utilize their people from there as teachers, involving them in teaching, because they have also lots of experience with research and even teaching background. And then there are others, those who can contribute in public health teaching. And of course, if the GPs, they may not be acquainted with the pedagogy of teaching, so they can be trained. And they can also be oriented with community-based medical education, competency-based medical education, and community-oriented medical education. So that is how we can enrich our faculty. The existing faculty can be enriched. So when we talk about involving, because the community wants some of their GPs can participate in teaching. Even they might feel, or if the GP might be interested. So in that case, if we want teaching in the community, we must involve somebody in the community also, so that there is a linkage with the institute and the community. And there I have mentioned about the GP or the NGO people. But why do we need it? If we take care of these 5 C's,
practical aspect of primary health care, who does it actually in the community? And combination, that is prevention with cure, who does it? Continuity in chronic diseases, who will do it? In the institution, tertiary institution, we have taken the responsibility of his treatment, management. But ultimately, who will manage him if he is in a chronic care or rehabilitative care? So there should be a continuity. That continuity can be established by an institute, by recruiting the GPs or the NGOs, those who are involved. And of course, collaboration with the colleagues and healthcare teams. Now, those who are involved in teaching, let us say we are involved in teaching, we must ask ourselves these 6 questions. What to accomplish by the teaching? How to engage learners, because that is most of the time we don't do, we just give lectures and sermon. So, do we engage our learners? So, how best we can engage, how much we can engage, that is how to meet the need of the learners. Did we ever ask them? We just given them a curriculum, this is your curriculum, go through this curriculum. Curriculum is for me. The students, did we ever take any of their views when we are developing that curriculum? That what do they want actually expect from the curriculum or the institute or the teachers? What do they want to learn? Did we ever? Never. We just impose a curriculum on them. This is your curriculum. We are the teachers. What we will teach, you will teach. And then we will assess you whether you will pass or fail. So this is the way the traditional teaching is happening. But there are changes happening also among the teachers as well as the institution and even curriculum development. And then how we are organizing a session, teaching session. So that is where, whether you are organizing in a classroom, in a small group teaching or large group teaching, or we are taking them out of the institutions in a session where the learner will be interested, interactive, and he will feel that this learning environment is a good environment or an enabling environment. And then how to be successful in that. Is the time sufficient? How much time you are given to the curriculum for learning? And learners are of different levels. Not that everybody will learn in 150 hours. Some might need more, some might need less. So whether the time is sufficient for learning for the students. So do we allow them for some more time, some more effort, so that they can learn better? This is again a common thing, preparatory course for the students who don't do actually. Students come from second year to third year, there is no preparatory class. They know here we have community medicine to learn, we have pharmacy medicine to, that is how they enter. And we don't guide them for study also. I am talking about traditional, exceptions are there. Individual attachments are not there at all. Teachers are not attached with individual students for any sort of counseling, not of education, even for self-study. Small group attachments, there are, but I think we should be very careful and we should be very focused that this attachment can be in the community, in the family. And sessions should be more or less interactive, not like lectures again, tutorial classes or other classes. Even lecture classes can be made interactive. So small group teaching can be made interactive. And then sessions utilizing healthcare professionals, we can take them to one of the centers where a doctor is, a clinic is there. Even in that clinic environment, he can learn under a professional. These are the teaching opportunities. Even specialists are practicing in nowadays in outside cities, even suburban areas. We can use them. So community-based teaching in rural setting is very different from urban and suburban settings. Lower range of services, exposed to diversity, students become a part as they live in the community, more concentration in learning, GPs enjoy student-teacher relationship. This is very interesting that students become a part as they live in the community. There are studies done in Canada and Australia. They have shown that even patient care is better when students are involved in the community teaching them. This is the advantage of students if we take them to the community. They can learn. What we expect from a public health professional, all these they can learn better, not in your institute, but in a community where actually ultimately you want them to serve. This is something interesting. If you just look at it, that the student after becoming graduate, he has a perception. Look at his perception, so high. But look at his employer's perception. See the difference. So employer will be utilizing him. No? Graduate, look at the perception of him when he is performing there. Look at the student's perception. I mean, when they become graduate. So you can see the lacking. So employers want to utilize them, or even the society wants to use them. You see where they are. That means the perception even varies. Now, if you take a sort of a, this is a study report. I did not mention because it was very hard to prepare and give you the reference. And now, on the basis of all these, WHO has recommended that there are focuses, we know now with other presentations here, that there is a need for integration in clinical discipline, integration in the health system, and there should be continuing professional development. These three should be there with other focuses. Now the focus criteria. Social accountability should be a vision, because Professor Mahfouz was mentioning about objective, aim and objective. But when you look at the vision, the teaching of public health vision should be social accountability. That how responsible we can produce a graduate who will provide public health service. Then of course the training program, teaching learning environment, resources including faculty, quality assurance, audit, educational management. So these are the focus criteria along with what I have mentioned about the World Federation of Medical Education, where the 9 areas there, you have to intermingle or mix them with that and then see that how you can integrate it and then make it a sort of a focus criteria for public health education, for accreditation. And that is where I thank you.
To this session, thanks to Professor Hall, has led to accreditation of public health focus criteria. It mentioned about social responsibility and social accountability that should form the core of the public health education system. They mentioned about World Federation of Medical Education standards, societal expectations, and the usability of the product that is getting out of the teaching training institutions. He has mentioned about teaching methodologies, changes to inculcate more skill, more competence, and as mentioned, the pedagogical approach, small group teaching. In fact, in today's scenario, at least in our country, we are seeing an aggressive effort to increase student intake. both at undergraduate level as well as postgraduate level, at all levels, in medical teaching institutions. From 50 students to 100 students, 100 students to 200 students, 200. We are now seeing we are in an era of medical college where annual intake at graduate level is 250. We are seeing this similar increase in postgraduate intake capacity. That is an aggressive effort from all-round effort to increase the number of manpower. Number becomes almost a sole criteria, and this increase, rapid overnight increase in number may seriously jeopardize the quality of education, because it's medical education, it is skill development, it is competency, the expectations of the society, whether the product is appropriate enough, skilled enough to fulfill the societal expectations of these expectations. So number versus quality, there is a conflict. I am not sure how this excellent principles can be applied in such a situation where increasing in number can be a core issue. Anyway, thank you, sir, for your excellent presentation and suggestions. Okay.
I now call upon Professor Sumit Dashmukh to hand over the certificate of appreciation to Professor Zahil Haq.
So the key issues that globally we have been talking about, and even in our region also, these issues are valid. The competencies are critical. Basically, we had session on competencies. We had session on education. We have session on public health cadre in the larger context of career opportunities for public health professionals, and then we have couple of sessions where we have the health workforce related issues, particularly public health and education, and e-learning in Brazil also. Then we have Bangladesh experience also, looking at some of the issues and what's happening in the context of education, particularly the objectives setting, and we deliberated on the Indian scenario of public health education. So I think we have very comprehensively deliberated on critical aspects of public health education. And what we could do is that if you have any specific question, although we could not get opportunity for after each presentation to deliberate on, and we have now time. So if you have any questions, we'll be really happy to take them. You can address your questions in the competency and the career opportunities of the academy, accreditation, objective setting. So let's have some questions from you. Then
Any
we also
question?
have some comments from our side.
Specifically to any speaker or in general to the
Yeah, in general also focus on public health education.
Yes,
Yeah.
Malika.
My question is as quality of education is declining because we are increasing the seats, and because now in West Bengal there are 2 colleges with 250 students, and I am associate professor in one of them. So we are having a tough time with small group teaching. So do you think that there should be some optimization, what is the optimum number, and that should be enforced by the Medical Council of India, because that seriously clearly public health related, at least at the undergraduate level, the minimum skills which they should acquire should be
The first one is that you said about the numbers. Now the country is in a dilemma where we need doctors, because if you look at our doctor population ratio, it is challenging as compared to other parts of the globe. So we need more doctors trained in the medical doctors. And therefore, you would have seen last 20 years, there are a lot of medical colleges opening in the country, and the government also taking decisions through Medical Council of India to increase the number of seats. That is all in the response basically to make the country self-sufficient in number of doctors, healthcare providers, because we struggle particularly in the health system in India where it is challenging to get the doctors actually. Doctor population ratio is more as compared to other parts of the world. However, having said this, it is also important to ensure that we need to produce more doctors. It does not mean that actually we just increase seats from 150 to 200, 200 to 250, and then challenges of pedagogy like small discussions and a lot of hands-on experience is not there. So, although there are guidelines of Medical Council of India, they are different from 100 seats or 200 seats or 250 seats basically. So it's basically to have adequate facilities in the institutes so that these challenges can be addressed. I would say that if numbers are increased, because we need more doctors, but we also need to ensure that adequate facilities are available. Even if 250 students also, sufficient number of classrooms are available, sufficient number of faculty are available, then still we can short, good discussions, and we say that small group work, that can still be facilitated actually. It is also linked up to the facilities. And reforms in Medical Council of India are obviously they are necessary, and even revisiting those guidelines, because the guidelines are also actually, a lot of guidelines are like policy or supervisory. Instead of that, even number of teachers, we say that the head count is very commonly used. Increase number of associate professors. But beyond that head count, what is inside the head is also important actually. You can't count only heads and say that there are 20 faculty. But so there are challenges and some reforms in faculty development are also required in that context. As long as the exposure to the students is concerned, rural health training center, urban health training center, as you say that they are on paper, actually it's variable from one institution to another institution. I can tell you there are certain institutions where rural health training centers, urban health training centers are quite well practiced. In some states they are really good actually. Students are posted, but again it also needs to be looked at. Just sending students to urban health center or rural health center, there has to be a structured program, what they are supposed to do. There has to be engagement of the leadership there, So it's not that you are posted in rural area basically. So that is again variable. Health systems connectivity is extremely important for medical education. There is no question about it. Because unfortunately then we work in two worlds. Medical schools, faculty in medical schools, students and everybody, they don't know anything about health systems. So even I would say beyond that, we should also engage people from the health systems in our teaching programs. If we engage them, we also, the faculty in medical colleges should also not only provide advice, but engage in some policy related work, but actually even providing healthcare also. That used to happen actually. Sir, you would agree that even in Samir, the associate professor of OBGYN, pediatric anesthesia, they used to do 2 times in a week or So there are certain even reorientation of medical education was the scheme basically which was initiated in India with the intention that there has to be a rural exposure, and so I think these activities needs to happen at even departmental level, institutional level, but we many times we blame Medical Council of India. But they said that we should have a guidelines. No, actual implementation happened at the institution level. So we as a faculty, we should take proactive and initiative to ensure that there is a program, students are posted, because there is a scope. It's not that, So I think if we proactively engage, it can happen. Dr. Saurabh, you like to say that is this topic which is close to your heart actually.
As a matter of fact, I think you have brought out a very important issue that what has happened, the entire medical education that has been designed in our country based upon the British pattern long time back, and very slowly, because Medical Council of India is one of the fossilized kind of an organization. It doesn't change fast. Even now it is undergoing some changes. It's okay. However, as Professor Durga said, we had opportunities under the home scheme and others, because ultimately when we go on teaching in the, say, even clinical medicine, in the medical college hospitals and related departments, we talk about etiology, but that etiology exists in the community, in the field. The social determinants of the health which influence the outcomes. We are talking about the pregnancy complications. Those are there at home in the society, and people are only talking theory part. We have not allowed ourselves to design our curriculum in such a way that it is possible. When the opportunity was there, the teachers came together and ensured that Rome is burnt. That was, I was coordinator of Rome for a few years, so I know what it is. The point that I am trying to say, however, in spite of that, there are medical colleges where the departments of community medicine, pediatrics, OBGYN, ophthalmology, internally coming together along with the field practice areas, and they are doing a good job. And still, and I can guarantee you, those, I was teacher for 10 years, the students, if they are taught with the community days, the topics become so interesting, and students start learning, and they also teach you. I also assure you, many teachers themselves don't know what they are teaching, and that could be one of the problems. So I think opportunities are there, and these opportunities can be exploited by internal mechanisms which exist. And what it needs is someone, and that's where the community medicine can take a leadership role, or PSM takes a leadership role, bring them on one platform and start this process. Please attempt. You may succeed, you may not, but attempt.
Okay. So Mr. Nazmi, one point.
Regarding number. Yeah. As Pranita was raising the issue, number, increased number, branch is a component of that. Why this undue emphasis? There has been one standard set, 1 per 1,000, we need a doctor. 1 per 1,000. Even if in next 5 or 10 years, with all this effort of increasing seats, we meet that goal of 1 per 1,000 doctors in India, will that address the issue of geographical imbalance in numbers of doctors? No, not. The societal imbalance? No. Because inequities, imbalances are inherent in our system until and unless we address social, economic and other imbalances, inequities. So doctors, only numbers will not serve the purpose. We have examples. Excellent examples put forward by our Professor Campus from Brazil, that is paraprofessionals, appropriately trained paraprofessionals, whatever with the nomenclature, and deployment of them, training them, monitoring them, setting their educational standards, curriculum, training curriculum. They were mentioning about small IT-based curriculum for reorientation training. These are policy issues that has to be taken up at Government of India level, because we have recommendations from Knowledge Commission, we have recommendations from so many other bodies. Everybody is telling that the competency is deteriorating day by day. It is not expected level, skills are not there, but things are going on. So, I think only numbers will not do.
As you rightly mentioned, actually, a lot of functions done by medical officer can also be done by the nursing professionals. So task shifting for allied health professionals, nursing professionals, the concept of nurse practitioners. So these models, even in Assam and even in Maharashtra, also that so some models are there. Even Government of India's commitment that BSc community health is focusing on all the components in there. The only thing is that I said that because numbers are also critical, because as you rightly mentioned, we will not be able to reach that numbers, and inequity will still persist. Even in developed countries where they have sufficient number of, several countries sufficient number of doctors, but inequity is still there basically. So inequity, although despite all our efforts, and we need to address that, it's not that we can allow it to persist basically, but we will have to have more people trained actually to have more healthcare providers. Because India is one of the worst classified actually as of healthcare providers. practice.
Actually, sir,
Because we need more nursing professionals also. We have actually, if you look at the ratio of nursing doctors also is But my concern is, even beyond numbers, lot of quality related issues are in our hands. That can happen even at the institution. Even given resources, because at times what happens is that anything comes, policy level, reform, in fact, Medical Council of India, it's easy basically to criticize those people and they are, criticism is due. We should criticize them. But reforms can begin at our end also. As faculty, at institution, what I can do to improve. Personally, if I can improve from my own pedagogy skills, I can be a good teacher, I can give. If I am saying that my very I not in the middle school or several years, if I say that my undergraduate students after passing graduation, if they are not able to conduct normal delivery, they don't know how to actually clean the wound and surgery, they don't know the medication. I am responsible actually. I am responsible. Who has prevented me that they cannot have those? See, the curriculum is generally MCF prescribes certain things. That curriculum is on paper mostly actually. I am more competency also at times it is there. They are written there actually. More important issue is implementation. And that is the responsibility of the faculty in medical college. If my students are not competent to do something, I am also responsible. Yes. I thought them MCF for that actually. So reform should begin at our home also. That's what is
another point. I think this may be a bit more. We start something, certain things, then we forget it. We started community health guides, community politics, exactly with this purpose that they will play an important key role in certain public health actions at community level, primary health care. Then after a few years, forget that. Then we started, well, in between Anganwadi workers under ICDS. You know the status. Now latest is under ISMOPH. The whole IMSCI program is basically meant to screen out critical conditions in child population, in children, by non-medical, paramedical trained worker, health worker. Whole IMSCI protocol is designed like that. Except training part, nowhere it is really practically operational. Not really operational. Be it ARI or diarrhea or malnutrition or severe bacterial pneumonia, this is a mechanism developed to address the issue, to screen out critical cases which will be screened by health workers at their level.
We notice that most of the things are pretty much geared towards public health as a medical field, which many disagree nowadays that public health should be separated from the field of medicine. The last speaker discussed that you can come up with accreditation bodies still using the medical education approach. Public health training here in India is still under the domain of medical education. But there are now many movements that public health should not be in the domain of medicine simply because when they become professionals, mostly doctors, will keep the profession within ourselves, thus pushing away others, which is against the primary healthcare approach that it should be simply because public health is transdisciplinary and multidisciplinary. Would you agree with my statement that that is one flaw and that we should move away from it being under the domain of doctors and under the domain of medicine?
I more than agree, but I would request
Partial agreement. Let us be men of the world. Let us see the reality. At least I am speaking in perspective of India. In India, the entire health system that is evolved, as I took in presentation, since 1946 board committee, that is given the leadership to the doctors and it continues. Now suddenly we start changing that particular model in totality, we will face a lot of resistance and a lot of problems. One thing is absolutely true, that public health is a multidisciplinary, and need not be doctor-centric. To that extent, we fully endorse what has been stated. However, doctors have a role to play as a public health leaders if they are trained in public health. It is not being a doctor is a disqualification. Being a doctor or an engineer, public health engineer, anybody who is trained in public health can be a leader, because ultimately when there is a structure, whether at whatever level, state, district, block, whatever level, you will require a leader. You cannot have everyone having the same passion. There will be a system, a structure which will be governed by the focal point, whatever the name that we have to give, coordinating point, leadership point, whatever. That leadership needs to be public health trained person. Basic qualification, he could be a social scientist, or she could be a public health engineer, a veterinary scientist, a nurse, whatever, all aspects of public health. So naturally I feel that principally it is accepted. However, when it comes to the translation of, sort of an implementation level, things need to gradually work it out and give opportunities for non-doctors to come up to that particular level with public health training.
From a global perspective, that public health should be a separate discipline from medicine. And I would actually take it one step further and say that sometime in the future, ministers should be called ministers of public health rather than a minister of health. That's a developmental thing, and when looking at the development of curriculum for public health, there are a number of different places where that could fit into. So there is a place for community medicine, which has just one small component of public health. There is a place for human resource management, which has an impact on the management of public health cadre, the planning for public health cadre. There is a place for planning and allocation of financing within the public health system, and that is very much an accounting and a financing specialization, and very different from knowing how to manage an intervention, a public health intervention. So curriculum in public health really does have to be multidimensional and at various levels within education, not only within medicine.
Thank you. Any other questions? Any thoughts? Yeah.
To all of you, my thanks definitely to Dr. Kaushik Mitra, who is Assistant Professor in my department, and all my audience here, because you are the person for whom everything is meant for. So, my sincere thanks to all of you, and wish you best of luck for next few days. Thank you.